Well, we've hit 8:30, so it is time to get started. Thank you so much for coming here today. My name is Vivian Ho. I'm a health economist. I hold the Baker Institute Chair in Health Economics at Rice University. It's good to see some new faces and some familiar faces as well. So this is the first time that we are reconvening since the pandemic. This is a biennial conference, and we change the topic every other year. We are focusing on affordability in this particular conference. There's a tremendous amount that is going on in the world these days in terms of war in other parts of the world. It's extremely difficult for many reasons, and you know that we have other events at the Baker Institute that are focusing on these pressing issues. I feel as though affordability was a challenge before the pandemic. We got through the pandemic, and affordability is still a problem. Affordability will still be a problem in terms of when these wars are ended, and hopefully that is soon. But this is a problem. It's not just the uninsured who are unable to afford their health insurance premiums. It's a question of people who actually have insurance coverage, but they are facing high deductibles, so they are facing high prices. And so every single person in this room, I'm sure, has a story about the price of a particular service that was just much too high. And we feel at the Baker Institute that this issue of affordability has really sapped the middle class of so much of their prosperity over the last 1 or 2 decades, and so we need to spend an entire conference on this. The logistics of today, we have 4 excellent speakers from across the nation who are going to be talking on their particular area of expertise. Each will speak for 40 minutes, and then there will be 20 minutes for question and answer. Please do not interrupt the speaker during their particular presentation. You'll see on the schedule there's a break in the middle. And in terms of facilities, ladies' rooms on this side and men's room on this side. And so with that, I'm going to introduce our first speaker. We're delighted to have with us Professor John Gruber from Massachusetts Institute of Technology. He is currently also chair of the department at MIT, and John Gruber is well known for many different. So I'll say, if you look at Google Scholar and you look at H-index, John has a triple-digit H-index, which is something that's not achieved by many economists. He is well known for his work, which marries the issues of health economics, public finance, and labor issues. So he's well known for everything having to do with crowd out of how public, in what cases does public health insurance crowd out private health insurance? He's also, one of my favorite papers is he showed how early Medicaid expansions actually led to significant drops in childhood mortality, something that we should be considering very strongly in our current environment of a lack of a Medicaid expansion here in Texas. But with that, I'm just going to get out of the way and welcome John.
Thanks, Vivian. It's good to be here. Vivian and I go way back, all the way to being on the job market together back in, 1863? I forget. But it's great to be here and to talk to you about healthcare reform. I'm going to sort of, I think it's hard to think about affordability without putting the context of where our healthcare system's been and where it's going. This is going to be a very light talk. You're going to hear about some fascinating new actual research from our remaining speakers. This is just sort of more of an overview talk about healthcare reform. So I just want to start by saying that one of the most frustrating questions you ever get when you work in healthcare reform is healthcare reform over? Is it done? Healthcare reform is never done. We are never going to, quote unquote, fix the US healthcare system. It is a constant, ongoing issue in terms of the critical issues of access and affordability to health insurance. So in that sense, I think it's important to start by thinking about where we've been in healthcare reform in the US, where we are now, and then I want to spend most of my time on where we're going and what the next big issues are. So to think about where we've been, I'd like you to cast your mind back to 2009. In 2009, life was very different from today. About 60% of Americans, actually not that different from today, had employer-sponsored insurance, and about 20% of Americans had public insurance through the Medicare program, which is universal coverage for the elderly, and the Medicaid program, which is means-tested coverage for the low-income group. They had insurance that pretty much worked. You know, there were things they didn't like, but by and large, it was insurance that worked. About 15% of Americans were uninsured. They had no insurance. And the remaining Americans were in this strange limbo of what was called the non-group insurance market. Now, the non-group insurance market back in that time was a strange market where insurers were free to discriminate against the sick. They were free to say, you're sick, so I'm not going to give you health insurance, so I'm going to charge you many times more for health insurance. You've gotten sick, so I'm going to raise your premiums or drop you altogether. You might ask, well, might say that doesn't sound like insurance. The whole idea of insurance, we pay when we're healthy and we take out when we're sick, and that's not the way it worked. It was really a fundamentally broken market. We're the only country in the world. People often talk about we're the only country in the world that didn't have universal coverage, or the only developed country. But I think folks didn't appreciate we're the only developed country that let insurers essentially discriminate against the sick, not to mention other forms of discrimination, say by gender, in the way insurance was priced and offered. So, moreover, despite this discriminatory system, costs were growing very rapidly in this non-group market. Costs were growing at about 10% a year. So even in this sort of discriminatory system, it was getting more and more expensive, even if you could get into the system to afford it. And on top of that, a lot of what people were buying wasn't real insurance. A lot of what people were buying were plans which had annual limits, which said, for example, we'll pay the first $5,000 in medical costs and nothing after that. Well, that's not insurance. It's sort of the opposite of insurance. There were lifetime limits. There were other limits that basically meant that people weren't really buying what we would actually consider insurance. So in a market where it was discriminatory, it was selling bad products, and costs were rising rapidly. Into this came the Affordable Care Act, which was passed in 2010 and really implemented in 2014. And look, you're not going to find someone more biased than me, but I think it was pretty successful. Okay, we lowered the number of uninsured in America by about 40%. And we fixed, I think what's fundamentally missed, people sort of focus too much on this number of uninsured. The more fundamental accomplishment is we fixed insurance markets in America. No longer can insurers discriminate against the sick or charge differential prices to the sick. We set up insurance exchanges, which made it easier to shop for insurance and gave people more access. And as a result, not only people gained coverage, but costs actually grew much more slowly. Now, let's be clear. Costs in healthcare never fall. Okay, there's two things that are always true in life. Okay, baseball games take too long, and healthcare costs rise. Okay, we've done something about baseball games this year. It's better. They still take too long. But healthcare costs are always going to go up. It's just a question of how fast they rise. And after the Affordable Care Act, healthcare costs rose much more slowly in this broken non-group market. So we fixed it so that it couldn't discriminate. We fixed give people more options. We fixed it to end the availability of these products which weren't real insurance. And despite all that, premiums, if you look at premiums on the ACA exchanges, they grew about 7% per year on average for the first 3 years, which was below where they were before the ACA. And the benchmark premium on the ACA exchanges are the same now as it was 5 years ago. Okay? So really growth has slowed dramatically. So this market has really been fundamentally transformed, where insurance was expensive, unavoidable, and not useful in many cases, to one where everyone's got real insurance, it's much more affordable, and many more people are taking advantage of it. Meanwhile, at the same time, overall healthcare costs started growing a lot more slowly. I've been focused on the non-group market, which is a small share of our insurance market, but actually employer premiums in the US since 2010 have grown at their slowest rate in measured history. Overall health insurance costs, some of you might have seen that interesting chart in the New York Times a few weeks ago, which showed where government budgets, where Medicare would have been if healthcare costs kept growing and where it is today. They've been pretty flat. Now, I put this secondary because I'm not sure how much credit the ACA can claim for that, let's be honest. The ACA claims some credit for that. And remember, we've saved, relative to what we would have spent, we've saved like $3 trillion. So even if the ACA gets a little bit of credit, that's a lot. That's a lot of money. But I think mostly it's other fundamental changes in the system the ACA helped maybe promote and build on that has really caused that. Now, while the ACA was a policy success, it was a political failure. I don't think that's a really controversial statement. Partly, I would argue it's because we passed a law in 2010 that didn't take effect till 2014. So you essentially had, there's an old Mark Twain saying that a lie will get halfway around the truth before around the world before the truth gets its boots on. Partly, if you have 4 years for people to say this law is terrible, it's doing terrible things, and there's nothing to point to say, wait, it's good, I think it was problematic in terms of people's opinion of the law. And quite frankly, I think it was a non-trivial factor in the election of both the Republican president and Congress in 2016. And many of us at that point thought, well, that's it for the ACA. These are people who campaigned on repealing the ACA. They had majorities in both houses of Congress and the presidency. It was over. But then a funny thing happened. It was far enough after 2014 that people started realizing they liked the ACA. And the ACA, for the first time, actually got out of the underwater territory into public opinion. More than half the people liked the ACA, and it turned out they couldn't repeal it. It came close, but it didn't happen. The ACA was weakened from the years 2016 to 2020. The number of uninsured covered by the ACA fell by about 20%. But then that's been reversed under the Biden administration, partly due to a lot of spending that took place during the pandemic, but it's continued since. The ACA is now covering more people than ever. It is doing so in a more generous way. Under current law, at least for 2 more years, no one on the exchanges has to pay more than 8% of their income for health insurance. And the uninsured rate in America, which, as I said, was about 15% in 2009, is now down below 9%. So I would argue that's a success. But things are not all rosy in terms of where we are today. They're not all rosy because, as Vivian highlighted, health insurance is still very, very expensive. Okay, the typical individual premium for health insurance is about $8,000. The typical family premium in the U.S. is about $23,000. The good news is, as I said, it's grown slowly. It's up about 4% a year over the last 10 years, which is very slow relative to historical trends, not that much faster than GDP. The bad news is that's still a lot of money and unaffordable for many, many families. But the bigger issue is rising out-of-pocket costs, which Vivian also highlighted. Deductibles under health insurance plans are up 95% over the last 10 years. And there's been a huge shift towards narrow network plans where people's choices are restricted. Now, narrow network plans pose an interesting trade-off. On the one hand, I think they may be, and Ellie's thought more about this than I, but I think they may be the single biggest contributor to slowing healthcare costs in the U.S. I think the fact that we have really put pressure on providers to lower their prices by restricting which providers or networks has been fundamentally transformative of healthcare systems. On the other hand, there's a lot of evidence that a lot of valuable providers are now being left out of these networks, and the insurers are actually actively excluding some of the best hospitals as a way to avoid signing up sick people. That they're saying, well, we're going to leave the best cancer hospital out of our network, not necessarily because it's more expensive, but because by leaving the best cancer hospital out of our network, people with cancer won't sign up for our insurance plan. So there's a fundamental trade-off here. Nothing is easy in healthcare reform. Nothing is black and white. There's a trade-off. I think on net, it's been a very positive development, but it's something we need to keep an eye on, both the rising out-of-pocket costs and the move towards narrow network. Meanwhile, there's reasons to worry that we may have hit a high water mark in terms of insurance coverage, that insurance coverage may be falling. Why is there reason to worry? The first reason to worry you've been probably seeing, which is the great Medicaid unwinding, which is a lot of the reason that health insurance coverage grew so much, actually grew during the pandemic and the subsequent, is because we essentially let anybody on Medicaid who said they qualify. Now, Medicaid is a means-tested program. It's currently, you're supposed to be only on Medicaid if you're under 33% of poverty, or in Texas under 28% of poverty, because you haven't expanded your Medicaid program. Okay? We can argue whether 133 or 28 or whatever is the right number. But whatever it is, that's the number. So how is that enforced? Well, once a year, they send out letters and say, telling us your income. And if people write back and say, my income's still below 133, they say, great, you can keep Medicaid. If they write back and say it's gone up, you're off. And if you don't write back, you're also off. So what happens is a lot of people just didn't get these letters, don't understand the letters, are too busy to pay attention to the letters, and even though they're still eligible for Medicaid, they get kicked off. This is a hard problem. You read about the Medicaid unwinding, you read like, oh, this is terrible, it's clearly a problem. It's not wrong that that people should get kicked off Medicaid. It's a means-tested program. If you don't like that, we need to have universal coverage. I'll come back to that. But as long as we have a mean-tested program, then people should come on and off the program. That's the way it should work. So it's not wrong that people are losing Medicaid. What's wrong is we've set up a system where many people are losing it who are still eligible. And that's a big problem we need to work on. The second reason is that a lot of the gain in insurance coverage were put in place by the Biden administration, in particular limits on what people had to pay in the exchanges, are time limited. They passed them for 3 years last year, so we got about 2 more years left. When those go away, costs will go way up on the exchange. Now, in the American political system, it's sort of hard to take something away, so maybe they'll just keep getting renewed. But, it's going to be an ongoing battle because it's expensive. So that's the other thing. That could lead to a significant increase in the uninsured if we raise costs again on the exchanges. So I think things are not sanguine. We've not solved the problem. And in particular, we still have 60% of the uninsured remaining uninsured. So that leads to sort of what I want to spend most of my time on, which is where do we go from here? What happens next? Let me start by pointing out that single payer isn't walking through the door, okay? A lot of people say, well, clearly all these faults I've laid out are solved with a single payer plan, and in many cases they are. But I've been saying the same thing for 20 years about single payer, and I haven't been proved wrong yet, so I'm going to keep saying it, which is that fundamentally, there's 3 fundamental political barriers in the American context to the single payer healthcare system. Okay, and I've never seen anyone show me how they're going to overcome them. Okay, the first fundamental barrier is that healthcare in America is paid for by an implicit tax. When MIT gives me health insurance or Rice gives you health insurance, they don't do so just out of the goodness of their heart. They do so as part of your compensation. And as a result, they pay you less. If they didn't give you health insurance, they'd compensate you more with wages. That's been shown by economic research. That's essentially the hidden tax that finances healthcare. So the good news, if we got rid of employer-sponsored insurance and went to one single government plan, we'd all get raises. But we'd also have to pay huge new taxes to pay for the single payer. Now, as an economist, I'd say, well, that all equals out. You get a raise, you pay a tax, it's all the same. The problem for the public is one is hidden and one is explicit. You're saying to the public, we're going to have this big new tax for single payer, and don't worry, you'll get a raise so you can pay that tax. That's not going to fly. People aren't going to trust that. That's problem 1. Problem 2 is the status quo bias, which is the system largely works for most Americans. I mean, they don't like it for various reasons, but they like it enough that the idea of giving it up for something unknown is going to be very challenging. And here I have real-world evidence. As I said, under the Affordable Care Act, we got rid of some low-cost, imperfect insurance plans. That meant some Americans had to pay more for health insurance. Probably on the order of 2 to 3% of Americans saw their health insurance costs go up because they were young, healthy people in sort of crappy insurance plans that said you can't do that anymore. I think every single one of them wrote to me, okay? It was a huge, huge problem for the ACA. One of the biggest problems the ACA faced was this: you can't keep your health insurance. Obama had said you can keep your health insurance, and people couldn't, and people were upset. That was 2% of Americans. And think of the press that got. Imagine we say it's about 60% of Americans or 80% of Americans. That's going to be pretty difficult. And the final problem is just the worst one of all, which is the health insurance industry is a $1 trillion industry. They're not going to say, hey, it's been great, we'll just roll our tents up and go away. They're going to fight, and they're going to spend up to $1 trillion. And companies that have that kind of leverage just don't lose in the American political system. Now, I'm not making what we call in economics a normative statement. I'm not saying any things are right. I'm just saying they are. And until someone can credibly come up with a solution to all of them, politically, we're not having single payer, okay? So we have to continue in the American context with our incremental approach towards healthcare reform. What does that mean? Well, first, that means making continued progress in the uninsured. Still having 9% of Americans uninsured is unacceptable, okay? We need to make progress on that. One way we can make progress is to, within our current system, is to use more of the kind of behavioral economics we've learned, the nudge ideas that we've been focused on in economics the last 20 years, which is through the idea of automatic enrollment. Many, many uninsured, probably the majority, are eligible for low-cost insurance, often free. What if your tax form, if you report your income and said, hey, based on your income, you're eligible for free health insurance, we've signed you up, here's your doctor. That would get a lot more people into health insurance. Okay? So we can use those sorts of tools. There are tools at our disposal which would not be that hard to use, which could significantly increase the number of insured in the US. But we have a fundamental barrier that we have to struggle, especially in places like Texas and California, which is about now 40% of the uninsured are undocumented immigrants. And there's zero political appetite, at least so far, for dealing with that population. We'll never get the uninsured number down to zero unless we deal with the issue that we have a large undocumented uninsured population, and that's just a really challenging political issue. Okay, then what about the underinsured? What about the fact that, as Vivian mentioned, we have millions of people who have insurance but can't really afford to get the care they need? Okay, here I think that we need to once again change the conversation to be explicit about what we mean about affordability. Okay, and here I read a New York Times article the other day about how terrible it was that this person who made $140,000 a year suddenly had a $300 increase in their student loan payments, $300 a month increase in their student loan payments. $300 increase a month in their student loan payments is $4,000 a year. Someone $140,000 a year of income could afford $4,000 a year in student loan repayments. I'm gonna go ahead and subjectively say that. Okay? We need to say the fact people have to pay money doesn't mean it's unaffordable. We need to define what affordable is. So when Massachusetts passed its healthcare reform, I was both honored and cursed with being on the board of 10 people that actually had to implement the law. And the law was unbelievably vague. The law said things like health insurance should be affordable and didn't define it. So we 10 people had to define what affordable meant. So I said, well, I'm an economist, let's go to the data. So I went to the data, and I went to data on spending and say, let's define affordable as, can you fit it in your budget after you've paid for all your necessities? And the answer is, people could afford a decent amount of money for health insurance. Now, you might argue with that definition, that's great, let's have a different definition. But let's as a society get away from debates of, oh, this poor person had to pay $1,000, to say, what is the burden they bore relative to what they could afford? Let's move to honest discussions about affordability. And then let's go ahead and limit spending based on what we think is affordable, like has been done on these exchanges. With the Biden plan, you could say 8% is the wrong number, but at least it's a number. At least it's an effort to say, here's an explicit cap. We should be doing the same thing with out-of-pocket costs. And we should do it on an income-related basis. Indeed, the Affordable Care Act, for the first time, actually put an income-related out-of-pocket cost. The richer you are, the more you have to pay out-of-pocket if you're on the exchanges. That makes a lot of sense, and we need to extend that. So I think we need to talk about affordability, but what I really don't like is these continued discussions of dollar terms rather than actually thinking about them in terms of what people can afford. So that was sort of hard and difficult, and guess what? That was the easy part of the talk. That was the fun part of the talk. Because then with the uninsured, it's about spending money. That's fun. Trying to control healthcare costs, that's not fun. Okay, because that's not about spending money, that's about saving money. And you can't fundamentally address affordability until you address the problem of our rapidly rising healthcare costs in the US. Okay? So basically, this is really, in some sense, the $65 trillion question. $65 trillion is essentially, the estimate's a little old, but the last estimate I saw of the US's unfunded obligations towards Medicare and Medicaid over the next 75 years is 65 trillion, that's with a T, dollars. And that's just because healthcare costs, we're aging. That's part of it, but mostly because healthcare costs grow rapidly. And so the question is, what do we do about this? Healthcare costs are incredibly hard, and the reason why is because it's seen in two seemingly contradictory facts. The first is that healthcare spending has a lot of wasteful elements. Best estimates are that about, so if you do either chart reviews or other things, you'll estimate about a third of healthcare spending in the US is just sort of not productive at all. Okay? At the same time, if you look over the last 60 years, where healthcare costs have grown from 4% of GDP to 18% of GDP, by many calculations, it's been worth it. If you look at David Cutler's book, Your Money, Your Life, he goes through the calculations of how much healthier we are versus how much we spent in healthcare. And the answer is, at a reasonable value of health, it's been a good deal. Healthcare sucked in 1950. I mean, if you had a baby who's underweight, they're 4 times likely to die in the first year. If you had a heart attack, you're 4 times likely to die. For the young, healthy people, if you hurt your knee skiing in 1950, you're in the hospital for a week, You're on crutches for 6 weeks, you have arthritis the rest of your life. Now you get scoped, you're on the slopes the next weekend. Healthcare's just way better. Okay? And actually, Cutler argues, and I think convincingly, that it's actually been worth it, that we are better off as a society with today's health levels spending 18% than we were in 1950 with those health levels spending 4%. Now, how can those two things be consistent? How can we be better off and wasting a third? Well, it's easy. The other 2/3 has been awesome. Okay? We've basically had an incredible productivity boom in healthcare alongside an incredible growth in waste in healthcare. Well, that seems like the answer's easy then. We just find the third and get rid of it. I mean, on average, you only spend a third more than Europe. We spend 18% of GDP, they spend 12. Get rid of the third and we're done. The problem is we don't know what it is. And we can look back and say what it is. It's Viagra and back surgery. Okay? But looking forward, we don't know what's the wasted third and what's the good third. It's hard to know. So the question is, what do you fundamentally do to control costs without sacrificing the health progress we've made? Now, one answer you say is, look at that New York Times article. We don't have to worry about it. We're done. Healthcare costs are flat. It's over. I am very not sanguine about that. I think that this is a temporary thing. Actually, if you look back, healthcare costs also did not grow relative to GDP in the 1990s. For the entire decade of the 1990s, healthcare grew slower than GDP. It then ended. This is going to end too. And the reason it's going to end, I predict, is because a lot of it is one-time factors. For example, the shift to narrow networks, I think, has been fundamentally transformative in lowering healthcare costs. But that's a one-time shift. That's sort of over. The growth in deductibles and out-of-pocket costs has really reined in healthcare spending. Well, deductibles are going to get about as big as they can before people can't afford it anymore. Okay? So I think the notion that this battle is won is wrong. It's an ongoing battle that we're going to have to continue to struggle with to think about how we control the cost for healthcare. And fundamentally, we have to decide between two paths. Big picture, there's two paths to decide between. Okay? Path one is to do what the rest of the world does and recognize the healthcare markets are fundamentally broken, and in broken markets, Econ 101 tells you need to regulate prices. Okay? Kenneth Arrow wrote the article that founded health economics in 1963. And he said, healthcare markets are broken in every possible way markets can be broken. Okay, when I teach basic economics, I just taught my basic economic model. What do I assume? You assume that people have perfect information. Well, God, you can't have less perfect information than healthcare. You assume there's many, many competing firms selling identical products. Well, clearly that's wrong in healthcare. Everything we assume about markets to make them work doesn't work in healthcare. Every other country in the world recognizes that and regulates their prices. We don't. As a result, a hip replacement in the US costs twice what it does in the average OECD country and 5 times as much as the lowest cost country. Humira for rheumatoid arthritis costs twice as much, 3 times the average cost country, and 6 times what it costs in lower cost countries. Okay? So basically, the answer is actually, as Uwe Reinhardt, the famous late great health economist, said, it's the price is stupid. The answer is simple. We just need to regulate prices. Now, the good news is we actually took a fundamental step in that direction, probably the most important step in that direction, at least 30 years, through the Inflation Reduction Act, which includes regulations on drug prices. It was a small step. Okay, it was a small step. It was a step we start with regulating 10 drugs, and 10 drugs the next year, then 15, et cetera. But it's a significant step forward because, and it's not really regulation, it's negotiation, but, it's basically regulation. Okay? So essentially, this is great news. Now, how optimistic you are about this depends on how you think about the politics. I have always said, 10 years ago, I'm not sure if we're going to regulate prices in America, but I'm sure when we do, we're coming for the drugs first. Why are drugs the easiest place to start? A, the prices are the most transparent. Okay? B, the fucking advertising is driving us nuts. Okay? I mean, anyone who has kids my age knows you had to sit there and explain to your kids why that guy kept throwing that football through the tire in all those Viagra ads. Like, why does he keep throwing the football through the tire? And like, well, he's just practicing his aim. Okay? Or even better, true story, my friend is a pediatrician in my hometown of Lexington, Massachusetts, had a 9-year-old then come in and say, hey, can you tell me about Cialis? And he said, why'd you ask me? He said, well, I was watching TV and it said, ask your doctor about Cialis. So I'm asking you. So people don't like the drug companies. They don't like the prices. This is the place where it's easiest to do regulation first. Beyond that, it gets, and I'm not saying that was easy. That was a long battle, and it's far from over. Okay, we'll hear much more about that. It's a long battle, and it's far from over. Okay, but it's nothing compared to the fight that's coming when we come for your friendly family doctor and hospital. Okay, that's when the fights really start. And let me start with a simple story to illustrate how hard this is. Once again, come back to drugs, but different kind of drugs. Not the drugs you get at the pharmacy, but injectable drugs that are reimbursed through Medicare's Part B. So when you go to the pharmacy and get drugs, there's, you cover your insurance, et cetera, you buy the drugs, you take them. Drugs which have to be injected and given other ways in medical providers, you go to your doctor to get the drug, and the way your doctor's reimbursed is they are paid 7.5% of the price of the drug. Okay, so if I go to Dr. Vivian and she gives me a shot like this that costs $100, she gets $7.50. If I go to Dr. Ellie and she gives me a shot like this that costs $1,000, same risk of carpal tunnel, okay? She gets $75. Well, that's dumb. So as a result, 20 senators wrote a letter to President Obama early in his tenure saying we should fix this system. And Obama took it seriously and proposed a new system where doctors would get paid a flat amount, a little bit based on the price of the drug. It should really not depend on the price of the drug at all. But Obama said, look, we can't go too far. Well, a flat amount plus 2.5% of the price of the drug. What happened? Well, 80 senators, including most of the original 20, then wrote a letter to him saying, how dare you interfere with this fundamental way that we deliver healthcare in America? You're going to kill Americans. What happened? Well, the oncologists got mad. They give the $1,000 shots, and they lobbied. And they got the senators to get upset and kill this. Okay? This is the fundamental challenge when you try to regulate unit prices. Once again, as Uwe Reinhardt famously said, healthcare costs equal healthcare income. If you try to regulate healthcare prices, someone's going to suffer, and they're going to oppose it. And that's the fundamental difficulty. So that is one piece. That's one path. That's hard. The other path is, in theory, easier, which say, look, we don't want to regulate prices towards a million prices. We're just going to put everyone in coordinated care organizations and just pay them a flat amount and let them figure it out. We'll set up these things called accountable care organizations, and we'll let them cover everybody's health care. We'll pay them a fixed amount, and then we don't have to regulate individual prices. Regulate that amount, one number. We just say it's one number. They'll compete to deliver care efficiently, and they'll figure it all out. And the answer is the kind of just like it's hard for the government, it's hard for the individual actors too, and they haven't figured it out. ACOs so far haven't worked. Now, ACO advocates will tell you we haven't tried them as strong as we should. We haven't introduced them as strong as we should. We haven't put enough financial pressure on institutions. That may be true. But so far, this sort of easier path is not working. The path of kind of let's just devolve the decisions to hospitals, who are probably the guys who are the worst financial incentives in the system, is not working. So we are really sort of stuck between a path that has been shown to work around the world, but is politically dangerous, and a path that we tried and so far hasn't worked, which is to just try to, the capitation plan, just give money to organizations, let them figure it out. So what do we do? Well, in some sense, we really need to, I would argue we need to just think seriously about the model of the IRA and drug price regulation, think how we're going to start getting there in terms of regulating providers. So for example, one proposal that's out there that I quite like is in non-competitive markets, the government would tie what hospitals can charge to the cost of Medicare, some multiple the cost of Medicare. Something like that. We need to actually start taking steps towards being where the rest of the world is, which has worked. Okay? And partly doing that involves another difficult decision, which is even more politically challenging, which is taking on cost effectiveness. Okay? What the rest of the world does is they actually say if a drug doesn't work, we're not going to pay for it, or we're going to pay for it as much as it actually improves health. Okay? That in the US gets called a death panel. Okay? We can't do that. But in some sense, we have to. That's where, if we are going to ultimately regulate prices, we have to regulate based on something. The thing we should regulate it on is based on how much these interventions improve health. We need to take that on. We need to take on seriously the notion that comparative effectiveness and the notion that we actually care about how much these interventions affect health, and that affects what we'll pay and whether we'll pay for them. And that's going to be an enormous challenge. Now, those are the sort of big questions we have to ask in healthcare costs. But on that last point, let me tell you sort of a dark cloud on the horizon, actually a good cloud in terms of health and a really dark cloud in terms of spending, which is we are about to enter sort of an unprecedented revolution in genetic therapies, cell and gene therapies. And these therapies are incredibly effective and incredibly expensive. And the answer I've given you, which is, look, let's just do what Europe does, doesn't work anymore. Let me explain why. There's a terrible disease called spinal muscular atrophy, which babies get. It kills them by age 2, and their life's miserable till then. You can't imagine anything worse. They've cured it. Okay, they made a cell therapy, which you put in a virus, you put in the baby's body, it goes through and cures their genes. It cures the disease. They don't have it anymore. They live. It's a miracle. This drug, Zolgensma, is priced at $2.1 million in the US. In Britain, which has a rigorous cost-effectiveness analysis, it's priced at $2.1 million. Because it's worth it. This isn't Humira where there's cheaper alternatives, and Britain prices it cheaper because you can get something else. This is a miracle. Miracles are expensive. And now that gets harder because now it's not just simply like we can save money through comparative effectiveness. We actually, if we want to save money, now we have to start making really hard decisions about drugs that are actually priced at incredibly high levels and are worth it. This is not just a one-off. My projections, my co-author Andy Lowe and Rena Conti, are that the US within 10 years will be spending $25 billion a year on these cell and gene therapies. And it's only going up from there. And this is a problem not for the US, it's a problem all over the world. Because as I said, this isn't something that cost effectiveness solves. If you want to regulate these prices, you've got to literally say, we're going to not pay what something's worth. It's hard enough in the US to say we're going to pay what something's worth as opposed to what people want for it. To go further and say we're not going to pay what something's worth, that is a very radical step. That really is rationing in the truest sense of the word. And that's going to be a real enormous challenge that's coming forward. And I think we need to think seriously about how we're going to deal with this sort of ongoing onslaught. Let me say one other thing about drug spending I think is important, that I think is sort of a common, maybe I'll anticipate a question here. You often hear, well, we can't regulate these drug prices, so we couldn't let them charge less than $2.1 million for Zolgensma because it'll hurt innovation. That we all know that the US pays the highest price for drugs in the world, and a lot of that money goes back into incredible R&D that's invented amazing medical solutions. And you cannot overstate how much pharma innovations have changed our life for the better over the last 50 or 60 years. So many people argue that if we regulate drug prices, a big argument in the IRA debate, Inflation Reduction Act debate, that it will hurt innovation because drug companies will have less money. And actually CBO, the Congressional Budget Office, heroically actually made an estimate. When the original Democratic bill, which would have regulated about 100-something prices, I think, they estimated it would have led to 10 fewer drugs being developed in a decade because of less R&D spending. So R&D spending did their calculations were as good as you could do. I think they're kind of bullshit, but they were as good as you could do. Okay, so 10's, the answer is, there's a large confidence interval around 10, but it's not a terrible first pass. Okay, and so they said, look, we won't get these drugs. Well, here's where that argument's wrong. And here I'll shamelessly plug another book I've written called Jumpstarting America with my co-author Simon Johnson. In this book, we talk about the history of what made America great, what made the American economy the engine of success it was from the post-war period till the mid-1970s, which was public science, public R&D. In 1965, in the US in 1965, 2% of our economy, 1 in every $50 was government-funded science. Today, it's 0.5%. Okay? And public R&D is incredibly productive. There's a fantastic research article by Pierre Azoulay and Danielle Lee at the Sloan School at MIT, where they look at the productivity of spending at NIH, and they do that by looking at people who win and lose NIH grants. Sort of it's random who wins and loses among people of very similar scores. And they look at what happens and look at the productivity. And they find that NIH funding, every dollar in NIH funding ultimately leads to about $4 in stock market value of companies that are created. Okay? And it leads to enormous new innovation. So we did a calculation. So go back to this Democratic bill, and where CBO said 10 new drugs would be invented. If you took, by Aslow's estimates, if you took 1/4 of the money that was saved by that bill and gave it to NIH, 80 new drugs would be invented. So you'd net 70 drugs and have 3/4 of the savings. So if you think about this argument that like we can't cut drug prices because it hurts innovation, it's sort of like saying we have to bribe these guys to do R&D. Well, that doesn't really make sense. If it's a profitless drug, they'll do the R&D. If not, we should be having the public sector be more involved in continuing to promote innovation in this country. So that's really kind of what I wanted to talk about. I can keep going for as long as you want me to, Vivian, if there's no, I mean, you know, I'll never stop. But I just want to make sure there's time for questions, and if not, I'll just keep going. So why don't I pause there and see if people have questions that they want to ask. I realize I've been really uncontroversial, so I'm sure it's pretty boring. You have nothing to say. Yeah. Wait till I'll get the mic.
Because for people online, so they can hear the questions.
Just wondering if you could comment on the role of patents and their involvement in raising or lowering or potentially lowering healthcare costs.
Well,
drug patents or anything.
Yeah, I mean, patents are, the standard trade-off with a patent is you end up with a monopoly, which charges high prices, but you get innovation, which you wouldn't if there wasn't a return to innovation. So we know the trade-off with patents. Patents clearly raise healthcare costs because basically all the incentive for innovation is expensive things. So what are the interesting issues in patents? Well, one interesting issue is sort of the patent system is fundamentally broken in terms of encouraging research on long-term diseases. This is a very famous paper by Heidi Williams, my former colleague at MIT. She showed that basically because the way the patent works is you file for your patent when you start your trial. So if a trial takes 10 years, then you don't have much patent protection left by the time the drug comes on the market. So really we have a fundamentally broken system in terms of drug companies want things they can try fast to get out so they can expand their patent as long as they can. That's a problem. There's all these patent thickets, what do they call them? Where basically companies will try to file all these patents to basically to extend their patent life beyond what it should be. This is part of what in some sense, you could think of the Inflation Reduction Act of regulation just saying, look, the patent thing's too hard to take on. We're just going to go for the result, which is regulate prices. So you could more fundamentally transform patents. But in some sense, the idea is, look, let's just go ahead and regulate the result of this patent thicket and these other problems, which is just go after prices. So patents are incredibly important. I think the other thing to recognize is why in the US are incentives always and only for cost increasing innovation? No one's getting patents for things that save money. Okay, why not? Because the incentives aren't there. How do we align those incentives to say research should go into actually things that save money? So I think patents are very important. They've led to fundamental transformation. I just think, they need to be reformed. And if we can't reform them, then we're going to have to do more price regulation on the back end.
Thank you for sharing everything. With about 160 million people under employer-sponsored health plans, the DOL now has a fiduciary responsibility that is being placed on the employers. With that flashlight going into the cost of care and managing the providers, the brokers, and all the intermediaries, they are now responsible to understand those things. And as we've looked to the waste part of healthcare, do you believe that the fiduciary model of healthcare, health advisors, will make a major impact in those 160 people's lives to lower cost?
Yeah, it's a great question. I mean, there's this deeper question of we have this bizarre role for employers in dealing with health insurance, right? It's just sort of not their comparative advantage. It's not clear why they do it. People do seem to like it. People sort of seem to like letting their employer deal with their health care for them. But that leads to this important question about fiduciary role, by the way, which extends to pensions as well. I mean, it's a very similar issue with pensions as well as health care. Employers have a fundamental fiduciary role, which is hard to know if they're really carrying that out correctly. I mean, one thing that is a mystery to me, fundamentally insurers have not really innovated in terms of fundamentally trying to lower healthcare costs. Insurers have just sort of acted like pass-through agents. Okay, why haven't employers demanded more insurer innovation? Why haven't employers taken a more active role in trying to control healthcare costs? You hear about employers doing this or that, but fundamentally employers are not out there making the noise they should about getting healthcare costs under control. My theory why is because my research from when I was on the job market with Vivian all that long time ago, which is that they just pass it on lower wages to their employees anyway. So it's not, they don't want to pick the fight. But I think employers have an important responsibility, and I think defining that and regulating it is one of the more fundamental challenges of the government. I don't envy those who have to do it. That's a difficult question.
What, in your opinion, are the biggest barriers to driving consumerism in our healthcare system, and do you think that would have any impact in lowering the healthcare costs?
Yeah, I mean, there's a lot of debate about consumerism. So basically, the fundamental economist view has been the right health insurance system should include cost sharing. Individuals should have some skin in the game, because otherwise they'll overuse healthcare. I think this has been sort of the gospel since the famous Rand health insurance experiment in the 1970s, which showed that when you made people pay for healthcare, they used less and weren't any sicker. That, I think, has been challenged along three dimensions. One dimension is it doesn't apply to everyone. And even Rand found that if for low-income sick people, it may be inefficient to make them pay for their health care. And I have a paper with Amitabh Chandra and Rob McKnight where we show for low-income, sick or older people, it looks like basically you don't really save that much money by making them pay for health care. So then that's led to a whole revolution, what we call value-based insurance design, of trying to think about ways to make insurance plans that don't just have indiscriminate cost sharing, but have cost sharing where we try to subsidize high value and target low value care items. That's hard to do. So I don't mean to criticize anyone, but when I was appointed to this Massachusetts Healthcare Board, I got to design health insurance in Massachusetts. I'm like, this is super cool. We have all these guys thinking about this. So I called them up and I'm like, what should we do? They're like, you should set high co-payments for low value care and low co-payments for high value care. I'm like, that's great, but what should I actually do? And they're like, you should set high co-payments for high value care and low co-payments for, for low value care. And the problem is it's hard to actually operationalize. So that's sort of one trick. The second piece that's difficult is just the affordability piece. And we want consumers to have skin in the game, but we want insurance to be affordable. I think that's solvable with thinking about affordability and having income-based out-of-pocket costs in terms of that going forward. So I guess that's just the 2 points I would make about that.
Is the definition of affordability fluid? And I ask because we are experiencing interesting economic dynamics right now with increased housing prices, increased, grocery prices. And so when you talk about being able to afford healthcare after basic expenses like housing and food, does that percentage change? Absolutely.
And look, affordability is not an economics concept, okay? What's affordable? That's just that's a social concept, an economics concept. As a result, I can't define it for you, but society needs to address it. The point is not that I know what affordable is. The point is that if we want to think about having consumers have skin in the game and being a fair and just society, we have to tackle that. We have to tackle the question of what is affordable. And it's hard, and different people have different definitions, and it's evolving, but it's not something we can avoid. I mean, some people argue avoid it by just getting rid of cost sharing in healthcare. I think that's a mistake. I think cost sharing is an important role. But seriously, so my colleague Amy Finkelstein has a recent book where she argues we should get rid of cost sharing in healthcare. And she's one of the nation's leading health economists. She's not very seriously about it, and she thinks the benefits are not worth the costs. I don't agree, but that's the seriousness of this debate, that a major figure in health economics would write a book saying we should get rid of cost sharing. That's the seriousness of this debate is being engaged. And I think that we need to really think about this, both in terms of how we design insurance in a proper way and how we decide what's affordable. Yeah.
So if there are other people who come up with questions, just raise your hand. But because I'm like you, I could just keep asking questions for the remainder of your time. So excellent talk. So many things to think about. So when, the hidden tax that we get with insurance
Right.
premiums, would it make sense? I don't think employers like this necessarily, but why don't we just, instead of just automatically taking the premium out of our paycheck, if we could put in writing, or somehow actually make people have to transfer the amount of their monthly premium out of their bank account, is it,
Yeah, I mean, it's really interesting. I mean, part of the ACA was, people actually have to be notified by their employer what the employer is spending on health insurance on their behalf. So we did try that with the ACA in terms of information. We didn't go as far as saying you have to actually pay for it. Look, of the 3 barriers I said to single payer, actually, the first is the most solvable. Actually, Elizabeth Warren had a plan for this, which was not terrible, actually, which was essentially to sort of figure out a way to essentially transfer the money directly from the employers to the government. So essentially the employers say, instead of paying your money, insurance companies pay your money to the government. And so people would be sort of neutral with respect to that. And I think that first problem is the most solvable of the 3 through some kind of mechanism like that.
Yeah. Okay, then there are other questions, but one other question. If you could talk more about Amy Finkelstein's book, because, you had mentioned the notion of automatic enrollment.
Right.
And that is not going to work for many Texans who just don't think that anybody should have free health care if they can work, which is unfortunate. But the other thing is when I hear her proposal, I partly think, this is Medicaid for all. And,
Yeah, so my colleague Amy has a book where she's basically proposing that we as society set a basic set of services and everyone gets them for free. And then you can go buy supplemental insurance for other things you want, which is basically, but it's not means tested. It's not Medicaid for all. It's basically it's basically European style healthcare. And it's a great idea. And for the reasons I laid out, I don't think it's gonna happen. Now, Amy would agree it's politically difficult. She said that's not her job. Her job's to lay out what she thinks is the right answer. And she makes a lot of compelling arguments. It's a great book. I recommend you read it. But I think, maybe because I've served in government, she hasn't. I kind of think we need to think about what we can actually get done in the near term. And I think it's a great guidepost and really just an excellent book. But I think there's a lot of challenge in implementing it in practice.
So Vivian stole my question because I was going to ask you the same one about her book. It's called "We've Got You Covered" for anybody who's looking for it. But I wanted to go back to the sort of cost effectiveness and sort of the challenges with new drug pricing and stuff. And are there any good ideas out there? And maybe we should save it for this afternoon when Stacy talks. But to say, okay, yes, it's worth $2.1 million, but really your cost of a reasonable amount of research and development, a reasonable amount of manufacturing costs and profit and all the rest would still only get us to $1 million, even though it's theoretically worth $2.1 million. It seems like there should be some way to solve that still doesn't.
Yeah, it's a great question. Yeah. So to be clear, that no one in the world does. So that would be radical. Essentially, you're saying, shouldn't we regulate drug companies like we regulate water utilities? When we regulate public utilities, let's turn the drug company to public utility. Basically, public utilities, we add up their costs, we add a profit margin, and that's what they get. And honestly, that may be the only, if we're in a world where there's genetic cures to cancer and heart disease, okay, literally we would double US healthcare spending in an instant. Okay, we will at that point have no choice but to make hard decisions about not letting people charge millions of dollars for each dose. And the question then is, how do you do that? And in a world where you can't do it through cost effectiveness, you got to find another mechanism. And I think actually public utility regulation model is not a terrible one to think about. I think Stacy could tell us the 100 problems that run into in practice. In particular, drug production is a joint production. There's enormous jointness in how you produce drugs. So to actually figure out how you regulate the price of one drug when it's produced by a company that does many different drugs, that's one problem. The other problem is drug companies need private capital. You need a high enough rate of return the private capital wants to invest, so you'd have to figure out what that is. So it really is, I actually love that model. I think it's got a lot to recommend it. I think it's, unlike what I said before, which seems easy because everyone else does it, that would be really radical. And I'd love to see more work on actually operationalizing that.
Okay, so a couple more questions. So you had mentioned linking out-of-pocket costs to income. Mm-hmm. But then I think of that in contrast to sort of David Cutler had an editorial in JAMA talking about you know, it's the physician's offices that are responsible for collecting these out-of-pocket costs, and it's just they just can't do it. So he's another one who's arguing just get rid of the co-pays because it's not working.
Yeah, I mean, look, once again, I think that that's a bit throwing out the baby with the bathwater. I think there's lots of problems with how we do our current cost-sharing system that could be addressed. I agree providers get left holding the bag way too often, but those are addressable. With a properly functioning government system, for example, a properly functioning system where basically we could actually have it come out of people's bank accounts. They could literally be, you know, you could essentially say, look, you get a card. That card has a balance based on your income. You flash it at the doctor. The doctor scans and says, okay, you're still below your deductible. Your plan says you give this much, and it comes out of, you know, you've pre-funded the card. It comes off the card. People have HSAs do that. Why can't every American do that? Yeah. So I think the idea, look, I'm very influenced by my own experience. I hurt my knee playing tennis about, 15 years ago, and a couple weeks later it was still hurting, and it was a Saturday, and my wife's like, you know, you've been moping around, like, you should go get it looked at. I'm like, it's a Saturday, so I have to go to the emergency room. So I went to the ER. They gave me an MRI. They said, look, stop being a whiny bitch. Your knee is fine. Just rest it. That cost me $50. That cost my health insurer $1,000. If they'd said to me, John, it's going to cost you $500, I might have waited another week, and that would have been the right thing to do. Okay? I think that the notion that consumers should have no skin in the game is just wrong. I just disagree on that. But that is, as I've said, that's a really open and active debate, and you should absolutely read Amy's book for See the Counter-Argument. She argues that, like David said, it's administratively infeasible, that doesn't do them much good. There's evidence that cost-sharing effects are indiscriminate. They're stopping people from getting care they should get. There's lots of arguments for just say, let's get rid of this whole cost-sharing thing. I don't think it wins the day, but you know, smart people are disagreeing on that.
Yeah, that's a very helpful response. Okay, so I don't want to run into
there's one question in the back.
Oh, there is. Okay, I think that's the last
Okay.
question.
I think that there's a really great opportunity to be able to have individual-owned HSAs. You know, we talk about, you know, what's the retirement future, but the power of the HSA on an individual basis would give someone such opportunity to save money for the future rising cost of healthcare, but you're only able to get it inside of a health plan now, that it qualifies to be an HSA. I have not seen a lot of public policy fighting for those individual HSA accounts to be available to the general public to be able to own in a tax.
Oh yeah, there's a lot of
benefit.
proposals for that, to try to let people in the exchange have HSAs and things like that. Let me be clear, I like the idea of we all have a card. I hate the HSA as a mechanism for a simple reason that the richer you are, the more money you get back, and why should that be? I mean, basically, why should it be that basically, because my tax rate's 40%, that I get 40% off my healthcare spending, and because my janitor's tax rate is 20%, he only gets 20% off. So I think we ought to do it, just HSA is the wrong model. Let's just give people an income-based lump sum. Here's in your account. You can put that in. You get a tax credit up to a certain amount. And so I agree. I think because of all the problems that we're finding that are being pointed out, people like David Cutler and Amy Finkelstein with our current cost-sharing system, we need to move to a new one. And I think the HSA model can be there. I just think the HSA as a vehicle is too regressive, and we ought to think about a more progressive vehicle for doing that.
But every year that we go by not doing something, regardless of rich or poor, we're still not solving the problem.
I agree. All right. Thank you very much.
All right. So we, you know, whenever we do this conference, we aim to have a range of speakers along the trajectory of their careers. So we're going to move from someone at the more senior level of their career to our youngest speaker here. And so I'm delighted to introduce Ellie Prager to you. Ellie Prager is a professor at Rochester University. She's also been at Northwestern University in their business school as well. And Ellie's kind of interesting because she works in two different areas. She does research on healthcare IO types of issues, and also works on labor issues. So she's got a terrific paper in the American Economic Review looking at the implications of hospital mergers and how those can actually lower wages for healthcare workers. And so that's something that the press has been picking up on lately. And so we've invited Ellie to come speak more on the healthcare IO types of issues today. And welcome, Ellie.
All right. Thank you, Vivian, for the generous introduction, and just broadly for having me here. I'm delighted to be here to continue discussing a topic that John so helpfully opened for us, and one that I started working on way back at the start of my Ph.D. dissertation research, which is whether and how we can get more bang for our healthcare buck by designing health insurance plans more smartly. And I'm going to focus my remarks today on just private healthcare dollars, so you should have in mind employer-sponsored plans, Obamacare, ACA exchange plans, rather than Medicare or Medicaid. Oh, this screen just went out, but I think you can still see. Now, insurance plan design broadly has two types of levers for encouraging more efficient use of healthcare dollars. One set of levers is aimed at providers, by which I mean, physician offices, hospitals, facilities, et cetera. And that'll be things like incentives and constraints targeted at those providers, like prior authorization. I want to focus today on the other class of levers, which are constraints and incentives targeted instead at patients, meaning basically cost sharing. So asking patients to pay something out of their own pocket at the point of care or after the point of care in order to access either certain types of treatment or drugs or treatments at certain places rather than going to, say, some other hospital. So I'm talking here about the gamut of cost-sharing designs, co-pays, co-insurance, deductibles, all of that. And let's see how this clicker works. Here we go. John didn't have to use this. Cheating. So insurers and employers, as we just heard, are increasingly relying on patient cost sharing as part of their plan design. The most recent data that we have suggest that national spending on patient out-of-pocket has gone from something like $300 to $500 billion over 6 years. That's like a 65% increase. That's pretty substantial. So, I think it's lovely that healthcare costs as a whole are growing slower, but out-of-pocket costs are not doing the same. And I think many of us have probably personally experienced this growth in the fraction of care that patients are expected to cover themselves. Or if you're young and healthy enough not to have experienced it yourself, then probably you have some loved ones or friends who are older or sicker who have had to deal with this. Now, is some of this increase explained by insurers and employers just shifting costs onto patients simply because they can, rather than for some nobler reason like that it makes the insurance plans function better? Some of it, yes, probably, but certainly not all of it. There are actually good reasons, as John said, to give patients some skin in the game and to ask them to pay something for some of the healthcare that they get. So, with a thoughtful cost-sharing design, it's possible to reduce total healthcare spending, and then you can use the savings to funnel it back into some sort of productive use. A productive use might be reducing premiums that patients pay, so you sort of pass the money back to the patients. Or a productive use might be actually keeping spending at the same level, but giving patients more generous coverage for something else. So let's walk through a scenario where this kind of argument works especially well. Let's say we take a patient in a self-insured employer's health plan. We take a patient in a self-insured employer's health plan who needs a routine colonoscopy. And let's say this patient lives a 10-minute drive from the nearest hospital. And if she gets her routine colonoscopy there, it's going to cost a total of $2,300. That's what the insurer and the employer and the patient, taken all together, will have to pay this hospital given the negotiated prices in this market. Now, the patient could also choose to drive 5 extra minutes to the next nearest hospital, and let's say the colonoscopy there only costs $900. Well, without cost sharing, there's not really any reason for the patient to do that, right? We haven't given the patient any skin in the game. Now imagine we introduce pretty modest cost sharing. So say we require the patient to pay $100 out of pocket to go to the more convenient but more expensive hospital, and we require her to pay nothing at all, or we require her to pay $25 out of pocket to go to the $900 hospital. Well, now there's a decent chance that she's going to choose to go to this less expensive hospital, which saves the system $1,400 that can then be reallocated into some useful use. So either you funnel that money back to patients in the form of lower premiums, or you funnel it back to patients in the form of more generous coverage for something else. Now, I recognize employers and insurers might choose not to do anything productive with that savings, but that's not my job today. My job today is just to talk about where the savings might come from and how we might achieve them. Now, because there is such wide price variation in many US healthcare markets, these kinds of plan designs can be genuinely useful for improving bang for buck. Of course, the example that I've given you is sort of simplified and abstracts away from many considerations like differences in quality and differences in income across patients. The point I'm trying to make is just that there are cases where cost-sharing designs are useful and can be beneficial for the health system as a whole and doesn't necessarily have to hurt patients. So there is some rationale for giving patients some skin in the game. That doesn't mean that all skin in the game is good. More is not necessarily better, because one important goal of health insurance is to insulate people from crippling medical costs. And too much patient cost sharing certainly can make it very difficult to meet that goal. Already, with the amount of cost sharing that we have now, research published in the prestigious medical journal JAMA shows that nearly 1 in 5 Americans have outstanding medical debt. And among those who do, the average amount is about $2,400, which for most families is a quite substantial sum. Small wonder, then, that nearly 1 in 10 Americans reports delaying or altogether foregoing medical care as a result of affordability considerations. So patient cost sharing can become simply too burdensome, but even cost sharing that is not too burdensome per se isn't necessarily going to be beneficial, right? Some cost sharing accomplishes basically nothing except to shift healthcare spending away from payers, so employers and insurers, and onto patients and their families. Instead, what you could do is reduce the cost sharing and have the risks of the variability in medical spending be borne by larger pools like employers or or small group markets. Those types of larger pools are much better suited to absorbing the risk. Essentially, it's like investing in a diversified stock portfolio instead of putting all of your money in a single company. That is the rationale, right? We don't actually, as a society, want to say to families, well, you have to bear all of your own risk, and we as a society are not going to help insure you against some illness that wreaks catastrophe on your family finances. So, cost sharing might be defensible if it helps reduce total spending in exchange for the risk that we are placing on patients. The problem is that many cost sharing designs put risk on patients and also fail to actually help reduce total spending. And in those cases, it's essentially, in my view, all cost and no benefit, or it's benefit to certain actors in the system, but not the system as a whole. So I'd like to use the rest of my time here today to discuss which types of cost-sharing designs actually are useful, meaning that we do get something back in exchange for the extra risk and the extra financial burden that we are asking patients to bear. So let's think about what an ideal cost-sharing design would accomplish. And I say ideal because this is only theoretical. You can't accomplish it in practice. It would simultaneously achieve 2 goals. First, it would reduce overall spending by nudging patients toward more cost-effective treatments or toward more cost-effective providers, and then that spending reduction can be used to finance something else that is useful. Second, the ideal cost-sharing design would also protect patients from financial risk by making sure that they actually don't have to pay very much out of pocket. Now, obviously, you see the tension there, right? You cannot do both of these things at once. You can't both make all of the care options free to patients and also expect to be able to nudge patients toward things that are going to be more cost-effective for the system as a whole. So we have to settle instead not for the ideal, but for the best achievable alternative. That means we have to accept that patients will be asked to bear some financial risk. But we shouldn't accept that unless we get something back, unless we use cost-sharing designs that are actually effective at reducing overall healthcare spending. Now, I find it useful always to visualize how this ideal design that's unachievable and the best achievable, and then just plain bad design all fit together. So let's draw a picture. Remember, the ideal design saves the system lots of money. So it's going to be on the right of this chart. It also exposes patients to minimal financial risk, so it's going to be on the bottom. So we're looking for something in that bottom right corner. A design that instead exposes patients to lots of risk, but also doesn't save the system any money, instead is going to be on the top left, right? That's just a plain bad design that I think there's no good reason to implement. Where we can make some progress is on the top right corner of this chart. This is where I think the best achievable designs lie. They expose patients to some risk, yes, but they save the system money that can then be diverted to other helpful uses. So here's just those latter two categories. We've got our best achievable designs, which have both drawbacks and benefits, and then we've got the designs that are just plain bad, which, again, in my view, are basically all cost and no benefit to the system as a whole. Let's finally talk about which designs actually fit into that top bucket. And here I got to be honest with you, for a long time we, meaning economists and health policy nerds, didn't used to know what kind of cost sharing worked and what kind didn't. We first learned that cost sharing worked at all to help reduce medical spending from the Rand health insurance experiment, which John already mentioned. This was conducted in the 1970s and early 80s. But then for like 30 or 40 years, we basically had very little improvement in our knowledge base about which types of cost-sharing designs work and why those ones work and others may not. And in the absence of evidence-based knowledge, I'm afraid that the economists did what we economists usually do, which is turning to abstract theory. And when you turn to abstract theory, the overly simplistic models that economists like to write down led us to believe that of all of the possible forms of cost sharing that are out there, the theoretical Platonic ideal is deductibles. Now we know that all cost sharing designs are not created equal, and actually that deductibles don't work that well. We're going to come back to this. We know that some designs don't work at all for getting patients to price shop, and some of the people in this room have done some of the work that shows this. We know also that some cost-sharing designs backfire by making patients cut back not only on care that isn't very valuable, but also on care that is very cost-effective, things like routine vaccinations. Patients just don't get them at as high a rate if you impose cost-sharing incorrectly. Crucially, though, we also know which designs do work. And even more importantly, we finally now understand enough to start drawing general principles about what works. And this is incredibly important. I can't overstate the importance of understanding not just that this specific design and this specific implementation worked, but what about it made it work. Because without that general understanding, you can't scale up interventions. You don't know which parts of the intervention you have to replicate exactly because they are critical to its success, versus which parts you can tailor to your patient population or to your insurance or hospital or physician market context. So understanding the underlying forces that drive what works and what doesn't is incredibly important and really has just begun to happen in the last 5 to 10 years. But that cutting edge research really has not diffused yet into how employers and insurers think about designing their health plans. And there remains to this day a lot of reliance on plan designs that we as a research community already know do not work. So before I finally tell you which designs have been shown to work and which ones have not, I have to first establish a common language by defining some terminology. So here's a list of both some of the most common types of cost-sharing designs and some that I think should be more common because we know they work, but sadly are not. We'll start with high deductibles, which we already talked about a lot in the first hour today. These are a cost-sharing design that requires the patient to pay basically the first X dollars of their healthcare spending for a given year before their insurance coverage kicks in. So a patient might have to pay for, say, the first $2,000 or $4,000 of medical spending that they incur in a year before their plan begins to pick up the tab. What this is supposed to do in principle is to nudge patients toward cheaper treatment options or cheaper providers, but in practice, it turns out it's very hard for patients to follow those nudges unless they know in advance exactly what healthcare option is going to cost across all of the options that they have available to them. And healthcare pricing is not exactly transparent, not exactly easy to navigate, and so while these designs are the theoretical ideal, in practice, the devil turns out to be in the details. They don't work that well. Coinsurance is supposed to achieve something similar. This is a design that requires the patient to pay typically a fixed percentage of whatever health costs they incur. So let's say you've got a plan with 10% coinsurance. That means if you go for a $500 treatment, you're paying $50 out of pocket. If you go for a $900 treatment, you're going to pay $90 out of pocket. Again, same thing as with the deductibles. This is supposed to nudge patients toward the options that are cheaper for the system as a whole. Very hard for patients to navigate. So enter price transparency tools, which I view not so much as a cost-sharing design, but sort of as an add-on or an auxiliary piece of the design. They're meant to help patients navigate designs like deductibles and coinsurance by letting them look up the prices for things in advance. I think Dr. Whaley, Chris, is going to tell us more about how well this works or doesn't work in practice, so I don't want to step on his toes too much, but the short version is that this is much more complicated in practice than it is in theory, as with everything in healthcare, of course. So let me tell you about two more designs that I actually am excited about now that I've pooped on all the others. Reference pricing is a cost-sharing design that sets, some baseline price level for, say, a type of healthcare treatment or a procedure. So let's say, using the colonoscopy example from before, we set a so-called reference or baseline price of $900. And then we're going to require patients to pay for every dollar beyond that $900. So if a patient goes to see a provider that charges $900 for colonoscopies, patient doesn't pay anything. But if a patient goes to a provider where it costs $1,100, then now the patient pays the difference, which is $200. And again, this is supposed to nudge patients toward providers that cost less. The difference between reference pricing and something coarser like a high deductible is that it typically comes with a much better information structure that patients can access. Finally, last type of design I want to mention, because it's my favorite, is tiered provider networks, specifically tiered provider networks with copays. These are a cost-sharing design that groups providers into 2 or 3, sometimes 4 bins or tiers, depending on their cost, tells patients exactly which providers are in which bins or tiers, and also tells them what their out-of-pocket price is going to be for going to a provider in each of those tiers. And that out-of-pocket price does not depend on what the patient has done to them, whether there are complications, whether the anesthesiologist is in or out of network. All of that is bundled into one simple copay that the patient can hopefully understand a lot better. So rigorous research has shown that these last 2 cost-sharing designs, meaning reference pricing and tiered networks, succeed at reducing overall healthcare spending. The other 3 designs, high deductibles, coinsurance, price transparency tools, at least in most of their implementations, although not necessarily all of them, all of those are much more common and they do not work very well. They don't actually do very much to reduce spending, at least through the mechanism of price shopping. If you impose high deductibles, people will just get less health care, but they're not going to be smarter about their healthcare decisions. And so those are exactly the kinds of designs I advocate against. They fit in my top left corner of the chart from a couple slides ago. There is lots of sound academic research supporting these conclusions and supporting the ranking that I showed you on the previous slide, but honestly, we would be here all day if I tried to review all of it. Having said that, Vivian assures me this is an audience that likes to nerd out a little on healthcare policy, so I'd like to give you at least a taste of the kinds of studies that support these conclusions. And as an example, I'll show you, one of my favorite designs, tiered networks, which I've been working on for a while. So I'll show you some stuff from one of my own studies. So let's talk through in a little bit more detail how tiered networks actually function so you understand what it is that we're trying to study here. Like any other provider network, a tiered network begins with an insurer negotiating prices with the providers in its market. So let's take a very simplified market. We've got an insurer and only 4 hospitals. And suppose the insurer has negotiated prices with those hospitals of $11,000, $17,000, $15,000, and $14,000 respectively. So the next thing the insurer is going to do is it's going to take those prices and say, all right, I'm going to group all of these hospitals into tiers. So the lowest priced, darkest blue hospitals are going to go in tier 1, which is going to have the lowest copay for patients. The middle priced hospitals, so the medium blue, are going to go in tier 2, copay is higher. And then the most expensive hospitals are going to go in tier 3 with the highest copay. Notice this is different from an outright narrow network because you're not actually telling patients that there's any hospital that they absolutely cannot go to and get coverage. But you are telling patients they're going to have to pay substantially more to go to those tier 3 hospitals. Now, the reason something like this can work better than a high deductible is because once patients know which hospital is in which tier, they can, first of all, figure that out by looking at just a single page of plan documentation, either online or on a brochure that their employer gives them, rather than having to use some clunky lookup tool for every piece of the various procedures that are going to all have to come together when they go to the hospital. And secondly, they know the exact price they're going to have to pay. So the information is presented to them in a format that's like as close to going to a grocery store and looking on a supermarket shelf as you're going to get in healthcare, right? I'm telling you, here are 5 boxes of cereal for you to choose from, and here are the prices associated with each of those 5 boxes of cereal, and I give you this information before you pick which box of cereal you're going to take home. Think about how radical this is. How often in American healthcare do we actually tell patients the exact price of their procedure or their treatment before they get it, not just at the place where they end up getting it, but all of the other places where they could have gone instead? So what do studies show actually happens in a tiered network? Well, here's data from one of my studies. This is from a very large employer, actually the Massachusetts State Employee Commission, which introduced tiered hospital networks in all of its plans in 2010. And in that year, so basically before these plans took effect, the plurality of patients went to the highest priced tier 3 hospitals. That's indicated by the red triangle on this slide. More than 40% of patients went to those. But within a few years, this changed substantially. Once they introduced the tiering with actually exactly the copays I showed you on the previous slide for consistency, only about 1/3 of patients were going to tier 3 hospitals, and more than 1/4 were now going to tier 1 hospitals. For the Massachusetts market, this is a really big shift because you want to know who's in tier 3 here? All the Harvard hospitals. Mass General, Brigham, Beth Israel. Some others too, but those are the 3 big draws. And if you know anyone who's lived in Massachusetts or gotten healthcare in Massachusetts, you know those guys have a lock on the provider market. So, what else can we do in studies like this? Well, using a data science method called discrete choice modeling, which I absolutely will not bore you with, researchers, economists can take data like what was on the previous slide and basically simulate out what would happen to relative patient volumes across these various tiers of hospitals, not only under the particular tiered network design that I showed you, but also for more or less aggressive tiered network designs. For example, what would happen if you raised the copay for tier 3 even further? So you made this look more like a narrow network, although not quite a narrow network. And turns out over time, patients sort of get used to navigating these plans, and you see volume shifting more and more toward the tier 1 hospitals and away from the tier 3 and even the tier 2 hospitals. This ends up having substantial effects on total spending. So the predicted average inpatient hospital admission goes from costing $19,000 at the outset to $17,500 per admission 3 years in. That's a 7% drop. Now, when I tell about audiences about these findings who are not healthcare audiences, they're like 7%. Well, that doesn't seem very big. That's like inflation for 1 year nowadays. I think in this room, I don't have to explain to you 7% is a huge amount of savings relative to generally what we think is achievable. So, one other thing I'll mention there is asking patients to face these kinds of tiered networks does put more of a burden on them. They do end up paying more than if you just said, well, every time you go to the hospital, it's going to be $100 flat. The thing is that we get more back in savings than we're asking patients to pay. And so we can compensate patients either in the form of lower premiums or, as I said earlier, in the form of more generous coverage for something else. So, it's costly, but there is at least some benefit. Now, what I've shown you so far is sort of some of the highlights from research on tiered network designs specifically. I told you also earlier that reference pricing seems to work pretty well. Chris has actually done a lot of the seminal work on that, and there's a large body of literature showing that reference pricing works well also. Now, I told you it's a really big deal that we know now not just which specific designs and their implementations work, but also why some of them work and others don't. The most important generalizable conclusion that we can now draw from this larger body of research is that these financial nudges in cost-sharing designs are only going to work if they are designed to be extremely user-friendly. So you need the level of simplicity of going to a grocery store and picking out a box of cereal in order for this to work. And in most cases, things are not designed to be user-friendly. I don't think I need to tell you that, but just for kicks, let me show you a plan description from my previous employer, Northwestern University. You can see here that the plan has 3 different buckets for different kinds of providers: in-network, out-of-network, and things owned by Northwestern itself, which it encouraged employees to use. And so you've got these 3 columns in your plan documentation, and they describe different cost-sharing regimes depending on which type of provider you see. Now, the trouble is, there's no list actually that you can easily look up that tells you which providers are in-network or out-of-network. Every time that you get something done to you, you have to go on this third-party website and wade through like 50 menus to figure out exactly which plan you're in and what's covered. And a third of the time, those things aren't accurate because the contract with that provider expired 6 months ago and the website didn't get updated. And even if you could figure out which provider is in which bucket, it doesn't tell you, for example, well, what is the price off of which your 20% coinsurance is going to be calculated? What is the price if you go to provider A versus provider B? Is it going to be above or below the deductible? If it's already above your deductible, then there's no point in shopping further because you're going to max out your spend. If it's below your deductible, then you should probably pay attention. My point is that designs like this are still too complicated. They're asking too much of patients, right? They make it too hard to figure out what the patient is going to have to pay. And the evidence shows they basically, for those reasons, don't help patients shop more smartly for healthcare. All they do is scare patients into consuming less healthcare overall, which, maybe sometimes that's good because maybe that'll prevent them from going to get an MRI for their knee, which is going to be fine in a week, as in John's case. But sometimes they're cutting back on care that they really need, and that backfires later on and results in health problems as well as bigger costs to the system. By contrast, cost-sharing designs like reference pricing and tiered networks make shopping for healthcare as close as we're going to get to shopping for groceries, right? It's not going to be perfect, but at least you can see the prices of all the products all at once, and you can see those prices before you've been asked to decide which box of cereal you are buying. And moreover, the price isn't going to change after you've already checked out at the checkout counter and then they run after you and say, oh, wait, there was a complication. Now we have to charge you extra for the raisins in your Raisin Bran. This is all really important because with something like coinsurance or deductibles, the prices that patients face can change after the fact relative to what they were told before. And that just makes patients much less likely to trust the price information that they're given up front correctly, which makes them less likely to even attempt to price shop. My argument is essentially that the level of simplicity that we have in the best achievable designs is a requirement for getting cost sharing to work at all. Healthcare prices in the US are generally very difficult to predict and to understand, even for someone like me with a Ph.D. in health economics, who's basically spent my entire career studying this stuff. Patients should not be expected to wade through this thicket, and they especially should not be expected to wade through this thicket and make accurate decisions in their most vulnerable moments, right? When they're sick, when they're stressed, when they're time constrained. They deserve prices that are predictable and comprehensible, both as a matter of fairness, and we can have a philosophical argument about that, but also importantly because that's the only thing that works. Now, some economists would argue that the degree of simplicity that I'm advocating for goes too far. They would say basically, a hospital priced at $14,000, like in that little tier diagram I showed you a bit ago, is still much more expensive than a hospital priced at $11,000. And those two hospitals shouldn't be in the same tier and shouldn't have the same copay charged to patients. They would favor more sophisticated out-of-pocket pricing that fully reflects the gamut and the range of healthcare prices that we face in the market. And I agree that would work better if all of your patients were robots with infinite information processing capacity, infinite patience, and no time constraints. But that's just not realistic. That's not how patients work, right? They are often making decisions when they're at their most vulnerable, when they're sick, when there is no time. And we have to design our healthcare system for humans in real-world situations instead of for experts who have infinite time on their hands. That message, unfortunately, has not gotten through to insurance designers and large insurance purchasers like employers. High-deductible health plans remain one of the most common cost-sharing designs still. So in the 10 years starting in about 2006, their market share among patients insured through an employer grew from 5% to 30-ish%, and it's basically stayed stubbornly high at that 30% mark, even after we learned conclusively several years ago that high deductibles do not work for getting patients to price shop. Worse yet, if you looked at the Obamacare exchanges, the penetration of high deductible plans is even higher than it is in employer markets. By some estimates, it's north of 50%. So what do we need to do? We need to transition away from these ineffective, bad cost-sharing designs. I'm a researcher, I believe in following the science, and in this setting, what following the science means is transitioning away from cost-sharing designs that both burden patients and don't actually do anything to curb total spending or help the system as a whole. So that means insurers should be shifting toward effective designs, or at least they should be getting rid of the ones that we know don't work. And employers that have the scale and the bandwidth to pay attention to this stuff should pressure insurers to give them that, right? As John said, employers have a role to play here. They can actually put pressure on the designers of these benefits. And you might say, okay, but there are a lot of small employers out there. Most employers, in fact, are small and just don't have a full-time HR person whose job it is to try to do this stuff. That's true. But even though most employers are small because of the way numbers work, most people work for employers that are large. So if you look at data from the Bureau of Labor Statistics, 2/3, if you want to be precise, 65% of people work for an employer that has at least 100 employees, and half, 48%, work for a really large employer that has at least 500 employees. So even if the small employers sit back and do nothing, which I think is perfectly sensible given all the other competing demands on their time, the big employers can move the needle here. Now, I don't want to absolve the economics or the research community of responsibility here either. We also need to do better. We are at least partly and maybe largely to blame for the current status quo that we have, because in the simplified economic theories that we used to rely on before we had all this great real-world data, it turned out that deductibles were the theoretically optimal form of cost sharing, and so, everybody did deductibles. But those economic theories that we relied on, they're akin to physics models that assume that every object is a perfect sphere moving through a frictionless vacuum, right? Useful, That's an informative abstraction. It can help us understand how an object is going to travel through space. Not useful if you're trying to design, say, an effective parachute, right? Then you actually have to think about air resistance. Similarly, the kinds of models that told us deductibles are the theoretical ideal assumed all sorts of unrealistic things. They assumed that there's basically only one kind of health condition. Patients can only get sick with one thing. There's only one kind of treatment for that health condition. That's not how the real world works. People get sick with different things. When they do get sick with something, there are often many treatment modalities available, and worse yet, it's often not clear which modality is going to work best for a given patient. So I'm not suggesting that we throw out the economics entirely. For starters, I'd be out of a job if we did that. But the economic models teach us that some cost sharing can be useful. But in order to understand what kind of cost sharing works best, what kind of parachute we should be designing, we need to go to the real world data. We can't just rely on these sort of robotic ChatGPT humans. It's just asking too much of the models, right? We can't expect an idealized model like that to help us understand the complexity of the real world. So, almost done. Let me wrap up. I think it's imperative that we shift toward better cost-sharing designs, or at least that we shift away from the bad ones. They're not doing anybody any good except for just shifting burdens from one payer to another, where the another ultimately becomes the patient and their family. I don't want to try to claim that the best achievable cost-sharing designs are some sort of panacea, right? Patients price shopping, even if they price shop a lot, is only going to go so far if even the lowest price providers we have still have prices that are twice what we see in other developed economies. So, to sort of abuse a fruit analogy, better cost-sharing designs can improve the flavor of the lemonade that we extract from the lemons that we have been dealt. But if you'll allow me to abuse the metaphor a little, they're not going to give us access to other fruits. You're still stuck with lemons, you're not getting apple juice. Those other fruits might be things like lower prices, more competitive healthcare markets, broader access to care for those who still don't have good access to care. Not a panacea. All of the problems that John outlined for us in the first hour still apply, but at least we shouldn't be doing the things that are obviously not working and obviously just not benefiting the system as a whole. So I'll end there, and I'm very happy to take questions. We've got one in the back.
Okay, then I'll start with one, because I've got I could ask multiple questions. This is great. So how do you, for tiered networks, how do you decide the amount that you set for each tier? Because, as an economist, can you you go on the axis in terms of the amount of savings and then the exposure to financial risk. Do we have enough data to sort of be able to estimate the ideal location on that?
We don't. We don't have enough data, and part of the reason we don't have enough data is because to answer the question of what is the right amount of cost sharing, economists will typically go to the data and say, well, we have very little information on something like a tiered network, so instead let's study what it has been around for a while, so deductibles and coinsurance, and we're going to look at how sensitive people's choices are to what they have to pay in deductibles and coinsurance, except those don't work. So basically, we're operating almost in a data vacuum, and I think employers and insurers have a big role to play here in starting to experiment, and maybe starting that experimentation on sort of well-defined, carved-out blocks of care. Like, let's say you do it for joint replacements, or you do it for primary care appointments. You don't try to do it for the entire system at once, and you take the time to iterate over a few years to try to figure out what those ideal amounts are.
I'd just like to give you hope to know that your ideal situation does exist as we applied in the real world with employers. It's there, but what's missing in some of this, or probably the biggest, is from an advisory standpoint, we work in a prehistoric industry, overcompensated for mediocrity. And therefore, the advisors, the brokers, have the greatest impact, and those that have the resolve will do the work, the harder work, to also get paid less. And so there is a very challenging issue in our industry to do this work, but we're able to build plans that have no deductibles, that have no copays. It does have steerage, it does have advocacy to take the responsibility off the employee, to have a guide, a chauffeur in this very complex system. So just want to share with you that there's a bright future coming. It's just the adage that we're just dealing with a lot of alphabet houses who just choose not to go that direction.
Good. Can you talk to some more large employers, please?
Any introduction, I'll work for anybody. So, yeah.
So I completely followed the theory from the patient point of view. My question is more from the plan point of view. What would stop plans from, the providers, what would stop the providers, the hospitals, to look at these price tiers and say, we're definitely more of a premium product. Let's go up a notch. Like they're too close to us. So like the Harvards, the Cornell, Columbias, the MD Andersons, where you'd start to see like, we're definitely better than tier 3, so let's go up. Like people are willing to pay that. So like, where's the mechanism to keep those sort of frozen for a longer period of time? I don't know if my question is making sense.
Let me try and state it back to you.
Okay.
And see how far we get. Your concern, if I understood correctly, is that the Brigham and Women's of the world will say, well, actually, I don't want to be seen as the lowest tier product. I'm going to deliberately raise my price even further, and I'm very happy to stay in tier 3, where patients have to pay more out of pocket.
Or the reverse.
The reverse can't happen, right? Because in order to get into tier 1, which is the lowest copay tier, they have to lower their price.
Right, okay.
And that works out great,
right.
Actually. And the research suggests that there is some movement, not as much as we hoped when these tiered networks were first introduced, but there is some movement of the highest price providers internalizing the fact that a tiered network means they will now get less volume, and some of them will drop their prices in an attempt to get into the tiers that will then give them more volume. And so that dynamic incentive for providers to price down is very much present, but not as strong as we had hoped, which is why I did not include it in the talk.
Hi, this is great, very interesting. But what's to keep if they're in the same bin, the 11,000 from going to the 14,000 if they know they'd be in the same bin anyways?
Very good. This is actually a game theory question, believe it or not. And the answer is that the insurer should not tell the hospitals in advance exactly what the cutoff is. Keep them guessing a little. These cutoffs do change year to year. And so the hospitals have to make some sort of calculus about, well, I don't know exactly where the cutoff is going to be. I want to have a reasonable shot at getting into the lower copay tier. And so I can't just go up to what I think the cutoff is because I might be wrong about where that cutoff will be.
Hey, so from the patient's perspective, if I look at the tiers, have you ever thought about how the patient will perceive tiers to be like substandard thing for their health coverage, and how that can probably put more pressure on the top tiers, considering everyone wants like a top-notch product for their health? So were there comments on that?
Yeah, I've done a little bit of work looking at this with my co-author Anna Sinaiko, and probably this depends on the details and depends on the implementation, but in the patient population that we studied, we found that the reaction patients had was entirely to the financial dimension, and that they weren't inferring things like, oh, well, this is a tier 1 or tier 3 provider, so they must be higher quality. All they were saying was, this one's cheap and this one's expensive. Mileage may vary in other markets.
Hi, and thank you so much for this. You've presented the tier in relationship to hospitals, so sort of an inpatient setting, which is generally a high-cost situation. But most of the time, patients are choosing the hospital based on a recommendation of their outpatient provider. So like with the recommendation of your hip replacement, right? Mm-hmm. So they're referred or they go to an orthopedic surgeon because of that surgeon's reputation or something about that surgeon, not because of the hospital in which they necessarily deliver care. And so so can you speak to the relationship between the physician that is making recommendations around admitting the patient that's different than going to an emergency room and being admitted that way? So generally admissions are going through the outpatient provider who has some sort of relationship. I can see where that might tier an integrated system to say, let's have a lower tier outpatient organization with a higher tier hospital, or some sort of other way of playing that because of the filtering through the outpatient system.
Yeah, the importance of referrals that you're describing is something that insurers realized after they first started introducing tiered networks. So the early iterations, like what I showed you here, really did treat inpatient hospital and sort of outpatient physician as two worlds unto themselves. And insurers fairly quickly caught on to the mechanism that you're describing. And there's a movement now that's not very advanced, but is going in that direction of tiering at the system level. So we're just going to take an entire hospital system and all of its affiliated physicians and providers who have admitting privileges there and put them all in the same tier. And you know, the hope there is that'll solve the referrals problem. There's even a hypothesis among some health policy folks that this all influences how quickly hospitals will want to acquire physician practices. I'm sure everyone's aware that there's been a great deal of vertical integration in healthcare in the last 10 years. And if you can acquire referrals by basically hiring people who used to practice independently to work for your system, that also influences how you're going to end up being tiered.
My question is really about getting to figuring out the price for the tiering, because at least here in Texas, as we've gotten more and more transparency data, what we're finding is that hospitals have tremendous variations in by different departments, by different service lines, so that they may have a really great price for maternity, but really terrible prices for cardiology or orthopedics or something. And so it's almost like you have to tier it at a service level, not at a hospital level. I'm just wondering if you've had any looked at that, or is that just another one of those, well, you just take the average and that's close enough? Or
I think you have to take the average, not because it's close enough and not because it's fundamentally a good idea, but because tiering at the service level makes it too complicated for patients. That has been tried, not at the degree of granularity that you're describing, but there have been attempts to tier, you know, for let's say you take inpatient care and you carve it out into 3 buckets, right? You have like maternity, peds, and then everything else. That's a version that's been tried. And it very quickly becomes overwhelming for patients, right? Having to compare 9 numbers instead of 3, that's already too much.
Well, having negotiated some of those contracts, I think it's also a matter of renegotiating.
Exactly. Yeah, so I think, you know, the real answer to this is that we need contracts to move in the direction of something where taking an average actually is representative of the entire price schedule, which currently it often is not.
Hi, so I was wondering when patients, they have this tier network cost information, copay information, it looks like there is a redistribution of patients across tiers. So I was wondering, do we know like what kind of patients that are more sensitive to the copay information, and what type of patients they are more likely to just stay with the highest tier?
We know a little bit, but not much. I'll tell you first why we don't know much, and then I'll tell you what we do know. The kinds of data that make it possible to run these studies typically have very little information about the patients themselves other than their medical history. So you can proxy for things like race and income and family composition, but those measures are very imperfect. Having said that, from those proxies, we do know that patients who live in lower income areas, and so we think are themselves lower income, are more likely to respond and redistribute. And so there is a distributional question here about whether we're then moving only low-income patients to what might be perceived as a lower quality provider, right? And I have almost intentionally glossed over that question here because the quality dimension is much, much harder to tackle, in part because we don't even really have good measures, right? You know, CMS now has measures of, for example, hospital quality, both process measures and outcomes measures. And since they began the program of collecting the information to compile those measures, hospitals have basically all converged to almost the same level, right? Because as we like to say in business school teaching, you get what you measure. And so if you tell people here are exactly the metrics on which you're going to be judged, then they're going to optimize for that set of metrics. And eventually they're all going to become indistinguishable on that set of metrics, even though there may still be underlying quality differences, but then they're not showing up in the data anymore.
Observation here. In my career is about a decade ago, there has the adoption rate for these tiered networks, what we were seeing that employers that are hospital systems, they were more likely to adopt these tiered network health plan designs, given that they had their own systems where they could put them all in tier one. But we used to see employer-sponsored, employers not in the health space, they had some sort of hesitance to go towards the tiered systems, and mostly what we were learning, the insights from that was they don't have much control, and this is a decade ago, on that price control that they can negotiate with the hospitals, and they stayed away. Their preferred thing was to go towards the high deductible plans, and that's still, as research is showing, that it's still been that way, and over a decade, I think, to your point, it will take a lot of employers to nudge their brokers and get those, they have to push towards this. But this definitely does work towards lowering the cost.
Thanks. So 2 points. One, I completely get the financial incentive side of what you're talking about, so love that. But just, I've got to give a plug as a provider that we operate in 50 states, and thinking about reference-based pricing and the dynamic of that market is just nightmarish for us to try to manage. So we've opted for transparency. I know that's going to be covered later. Small plug for that. But follow on to the point here. We spend a lot of time with employers who have tried so hard with their insurance companies and have just frankly given up and have said, we're going to go create plan design, and I'll use air quote, plan, outside of insurance. We're going to buy direct, non-emergent surgery, direct primary care, mental health, some pharma, imaging, which is where we fit into the care journey. And I didn't see free in your financial incentive, but the employers are saying, we see the steerage, we see the value, we see the quality, we vetted all these providers, call it tier 1, 2, 3. We want you to come here, and we'll offer that as a free benefit. Well, you have your insurance over here, all the plan design that you talked about. So I was curious how much of that kind of outside of insurance, even free, fits into your model and your studies.
My understanding is that that's still quite unusual. Mm-hmm. And you I'm sure would know better than I would about that. In principle, there's nothing stopping you from saying, well, I've got this tiered network, and tier 1 costs you $0. And tier 1 might be outside of your regular insurance plan. Mm-hmm. It might be this extra set of providers that I have contracted with directly. That would still count. Mm-hmm. I can't say much more because I don't like speaking outside the data, and I have not seen the data. Again,
I was just curious how it fit into your models. Again, trying to stay to the economic side here, because these employers are truly trying to drive behavior and economic impact for them, and quality care, all that. So.
Yeah, I mean, look, I think given the distributional concerns and given how high out-of-pocket costs have crept, and the fact that it is unaffordable for many people, even by John's sort of income-based definition, tiering or reference pricing where the cheapest option costs $0 out of pocket is exactly the way to go, right? Mm-hmm. We don't actually want to be telling people, well, don't get your knee replaced, don't get your hip replaced, right? That's a really big hit to people's quality of life. But what we do want to say is, well, if that provider costs twice as much, then we want you to pay for some of it. So I'm totally in favor of tiering with $0 at the top tier.
So, great talk. Do insurance companies have incentives directly to do this and simplify the benefit, or do you think it only is operationalized through pressure from employers?
They have some very indirect pressure, right? A self-funded, self-insured employer, there the insurer isn't going to make any money, essentially, by making care cheaper on the whole. Insurers still do compete also for partially for fully insured business where the insurer is bearing the risk. And there, being able to price their premiums more competitively does help them attract more business. Unfortunately, the research has also shown that in that sort of smallish employer market, employer choices over insurance companies are very sticky. And so the strategy that insurers often take is they offer a very competitive premium or total cost to the employer the first year that they bid on a contract, and then they raise it over time, and the employers don't switch because switching is hard and a pain, and they don't want to go back to their broker. So there's not as much pressure as there should be, and I imagine that that probably explains why we haven't seen greater penetration of the better cost-sharing designs.
So I guess the Massachusetts Commission that you studied, did they save enough money to, lower the premiums for the workers or increase their wages? Like, what did they do with the money?
Yeah, they didn't increase the wages. That commission does not actually control wages, right? The Massachusetts state employee system has sort of a benefits board that's a quasi-state agency and is separate from the wage setting process that also insures many municipal employees, police departments, things like that. And so what they did was they basically cut the growth in premiums over time. So rather than plowing that money directly back into salaries for the patients, they lowered healthcare spending over the longer run. That meant that people's out-of-pocket premium contributions grew more slowly than they would have, but they didn't literally get money back. But, as John said, it's all about reducing the cost growth rate. If you can get the growth rate down, then we'll be in a better spot 50 years from now than otherwise.
So more money in their paycheck after, because the
After premiums.
Yeah.
But only relative to what the future growth would have been, rather than
Right.
now it's $50 cheaper than it was last year. No, it's still more expensive than last year, but not by as much as it might have been.
Yeah, it would be interesting if they could have done a comparison relative to other, premium contributions in the same geographic area.
So there is some of that actually, because some Massachusetts municipalities were able to move into these Massachusetts Group Insurance Commission plans, and when they did that, they just outright saved money. And I have an incomplete study that may be a zombie paper forever, showing that most of the savings from that got plowed into local school districts.
Okay, so my husband's also a faculty member here, and he sits on the benefits committee. And when, the HR person tried to discuss with the faculty ways to save money, and it's faculty and staff, the immediate response was, we don't trust our employer to share the savings with us. So my, once I finish teaching this semester, my goal is to try and work with the HR office to convince Rice to move to a tiered network. Because I almost feel as though, it's not in the broker's interest. As you've mentioned, it's just not in the broker's interest. And it's almost as though health economists, if we want this to happen, have to sort of try doing this in our own organizations, and if we can demonstrate a significant cost savings, then it becomes information that larger employers can act on. But I don't blame them. HR officers aren't economists, so they don't have the expertise to do this. Do you think that's just nuts?
I don't know. I feel like, very fortunately for me, this is above my pay grade. My employer probably wouldn't listen if I told them how to design their benefits. But I would, I think that the employee trust problem is a real one that you have to solve, right? Because especially the fact that when employers save money, the way that they can pass that through to workers is typically by reducing the growth rate in what the workers will be asked to pay in the future, rather than by actually saying, okay, well, here's money back, right? And that's very difficult for people to process, because you don't know the counterfactual. You don't know how much your premiums would have gone up in the absence of the move to the tiered network. So I think you have to find ways to compensate people in the immediate term. So, an obvious place in my mind is by lowering deductibles. I imagine that Rice's deductibles, like everybody else's, have crept up pretty high. And so if you told people we're going to get rid of the deductible, or we're going to bring it back to $500, and in exchange, we're now going to tier your provider network, that sounds to me much more palatable and politically sellable than saying, well, we're going to move to a tiered network, and maybe your premiums will grow slower, but we're not making any promises.
Yeah, that's a really helpful point. So following up on Dr. Russell's question about, and you have to tier the whole system, which makes a lot of sense. So I'm also worried about possible kickbacks Because I listen to this podcast, Pivot. It's on it's actually one of the more popular, sort of tech and business types of podcasts, mostly because it's entertaining. I learned stuff. But they get the healthcare stuff wrong every time. And so the two hosts start talking about how wonderful One Medical is, and they say, oh, I go in there, it's great service. The problem is One Medical, when you need more specialized care, they actually refer you to the highest priced system. So to me, it doesn't save money. So that's one example. I talked with someone earlier this week who's with a concierge medical care, which I understand, they have the money to do that, and that's great. But then I say, excuse me, where do you go? Where do they refer you for specialty care? Again, it's the highest price system. So any thoughts on that? What do we need in terms of regulation?
Oh man, enforcement is so hard, right? In my other life outside health economics, I'm an antitrust economist, and I'm very sympathetic to how hard it is to say, well, we're going to have these laws on the books that say what behavior is not legal and then expect people to follow those laws. But there are anti-kickback laws. There are already laws on the books that prevent physicians from self-referring. Those are some of the reasons that have sort of constrained the growth in physician-owned hospitals, for example. And I hope we can leave it to the enforcers to catch that stuff. The Medicare fraud lawyers are really good at it. Maybe we could have them prosecute stuff in the private market too. That's all I got.
Okay, if someone else doesn't have another question, I have one more question, then we should probably.
I think you're good. Oh, one in the back.
Sorry, I didn't.
There's an opportunity between the concierge medicine and what you just mentioned, the high price. The direct primary care model that exists, capitating tremendous amounts of expenses on about $100 a month fee or even less for individuals. There are great solutions out there. And I think that at the end of the day, the individual has to be cared for and the employer has to find solutions towards it. But again, it really goes back a lot to the broker. The broker is the steerer and sort of knowledge keeper of this entire thing. And so we have to create more accountability. And luckily, the fiduciary responsibilities will shine that light on all of these opportunities, because you now, as a fiduciary, will have to search and research all of these components of the health plan. And it's going to be a beautiful future if the enforcement through the DOL occurs. It'll be outstanding.
So that's always my follow-up question, which is exactly Vivian's question. How do we make sure that these things are enforced, right? It's easy, I think, to say there is now a fiduciary responsibility and we're going to check whether brokers are doing more research than they were before. But how is an enforcer going to know if they're doing as much as they should have been doing, right? That these enforcement problems are genuinely thorny, and I think as economists, we're usually pretty ill-equipped to think about that side of the equation, even though, we can put it in our models. We're not very good at actually implementing it in the real world.
Okay, I'm just going to squeeze in one last question. It's related to what John said, and someone asked about this. My guess is that, I mean, do we link the amounts of the tiers to income? Because, of course, the highest income people can always afford tier 3.
I just think that that's so hard. It's so hard to implement. Maybe in the world that John described, where everybody gets a health card at the beginning of the year like they have in Taiwan, and sort of all of the provider systems talk to each other. We can't even get electronic health records to talk to each other across departments in the same hospital right now. You go and you get your surgery, they send something down to radiology, radiology can't open the file. So as a practical matter, I deeply doubt our ability to implement something like that correctly.
Okay, well, thanks very much. We're going to take a break, and we're going to start with the third speaker at 10:55. Okay, we're ready to start with our third speaker of the day. Delighted to have Dr. Chris Whaley with us today, and particularly because Chris is just sort of reorienting. He's been at Rand for many years, and he's just moved to Brown University 2 months ago, I believe. Now, Chris is someone that, Health Affairs is the top health policy journal that academics aim to publish in. And honestly, I feel like every other issue, it comes out once a month, and every other issue has a paper by Chris these days. He is so prolific. He has worked in a number of different areas. As Ellie mentioned, he's done some of the seminal work on reference pricing, showing how effective it is in saving money for California public employees. He's done tremendous work on the effects of vertical integration between hospitals and physicians on costs, and he has been really the mastermind of the lead up to the price, the sort of larger price transparency efforts that we have today by running experiments through RAND. And so you'll hear this RAND 3.0, 4.0, now we're on 5.0. I hope you mentioned that during your presentation today, Chris, and well, welcome.
Great. Really excited to be here, and thank you for the introduction, Vivian. We were talking yesterday at dinner that I think this is like the nicest and the coldest weather I've ever been in Houston, and so it's really nice to be here this time of year, but this time of year only. So we heard a lot, on many of the challenges of the healthcare system, particularly in John's talk this morning. And so, John spent 40 minutes going over basically the same thing that I have here in one slide. So just kind of 3 motivating points on how we think about the role of prices in the U.S. healthcare system. And so you can call these facts or observations, but I'm going to call them points today. So one is just we spend a lot on healthcare, more than any other country in the world, and for roughly the same or worse, slightly worse outcomes than comparable countries. And importantly, we spend more, don't appear to be getting much out of it, and that money comes at the expense of everything else that we could be spending that money on, whether that is take-home pay for workers, funding education, lower tax rates, or what have you. And we talk a lot about how much we spend on healthcare, but we don't talk much about what that money comes out of and what we could be doing with how much we spend on healthcare instead. The second point is that I think it's pretty widely acknowledged that we spend a lot and have high spending on healthcare, largely due to prices. If we look at patterns of utilization, or how much care we consume, or the health of the population compared to the United States and in comparable countries, it's more or less the same. But even on Medicare prices, the prices that Medicare pays are much higher than any other country, and the commercially insured populations are about double what Medicare spends. And so on kind of any dimension of price, we spend a lot, in the high spending in healthcare in the United States is really driven by prices. And then just the final point, and really what I'm going to talk about today, is that not only are prices high, but they're also very variable. And so we have a tremendous range in prices, and they're also incredibly opaque. And I think these 2 points together, just the variability and the opaque nature and non-transparent nature of prices, really drives a lot of the current frustration with the healthcare system. So many patients, their frustration with the healthcare system really kind of arrives when they get a bill in the mail for a service that maybe they do or do not remember getting, and it has this amount that says the patient owes. And for many patients, that amount really is not connected to anything that they can put their hands on and say, yes, this is a service that I got this $1,000 procedure, and what I received, that service aligns with the bill I'm getting. And so also just to kind of clarify, when I talk about prices and what I'm going to talk about today, I'm really focused on the employer-sponsored insurance population in the United States. So collectively, this is about half of the country, about 160 million people. Roughly 20 million or so people receive insurance on one of the individual market exchanges. But most people in the United States who receive insurance actually get insurance as a form of compensation from their employer. Collectively, employers spend over $1 trillion on healthcare. Now it's about $1.5 trillion per year. And so employers, through the employer-sponsored insurance system, are doing a pretty important role in financing the U.S. healthcare system. And if we look at kind of where the money is going, the largest chunk of the pie, just under $500 billion, is actually going towards hospitals. And so employers are spending a lot on healthcare and also covering a lot of individuals for care services. And this is a huge and important market, but it's also a market that has lots of challenges that lead to policymakers to consider what to do. And so if we just look at where this $1.2 trillion or now about $1.5 trillion comes from, it really comes out of other types of compensation that workers have experienced. And so if we look over the last decade, there's been a huge explosion in deductibles. Using data from the Kaiser Family Foundation, there's about 160% increase in the average deductible amount for workers. Now, especially for lower income individuals who receive employer-sponsored insurance, it's not uncommon to have deductibles of $5,000 or more. Premiums have increased by 54% over the last 10 years. At RAND, where, as Vivian mentioned, I recently left, our premiums are now $30,000 to provide insurance for a family. That comes directly out of paychecks. And we see that in worker earnings have increased by only 20%, which is actually less than inflation. And so if we take this forward through the last couple of years, these numbers have even gotten more drastic. And so I think there's a growing concern by many researchers and policymakers that we're essentially financing the growth in healthcare costs by taking money out of worker paychecks and paying for pay increases in the form of premium and healthcare dollars. And so that certainly, I think, raises lots of concerns how we think about the equity of the insurance system and the equity of the healthcare system in the United States. What really drives a lot of those increases in spending actually tends to be not just high prices, but tremendous growth in prices. And so if we look, not just at healthcare, but across the economy, and look at where kind of prices have increased the most or actually gotten better, healthcare and especially hospital services have experienced the largest increase in per unit prices over the last 20 years. And so just looking from 2000 to now, hospital services have increased in unit prices by over 200%. We in higher education, maybe need to get off our high horse because we're number 2 at 160% increase. And medical services have also increased by 120%. And so the price growth that we see in healthcare drives a lot of the spending and the growth in spending, and we haven't seen the same level of price growth in other services. And it's not just something that, maybe we think that healthcare uses lots of technology and, that's why we're spending a lot. But if we look at other very, technology driven places of the economy, such as cell phones and computers, those are areas that have actually experienced reductions in prices. And so there's something unique in how prices are set in healthcare that leads to the huge growth in prices that we see. And part of understanding that price growth, I think, really comes into understanding how prices are set on the commercially insured side. So, typically we think that in a lot of these, game theory bargaining models that Ellie can tell you all about, prices are set through a negotiation process where you have some process where patients are choosing their insurance plan, and patients also have the best doctors that they want to go to, and so there's some type of negotiation between patients in terms of what type of premium am I going to pay that's going to allow me to go to certain types of doctors, and then also providers and insurers are negotiating on, we're the best game in town, and so we get better prices because if we're not in your network, then no one's going to buy your insurance plan, Anthem or United. At the same time, we have employers kind of off doing their own thing. So at least I'm sure when most people are choosing their plan in this room, it's not like you have a huge set of options. Your employers have said, essentially, these are the 3 or 4 choices that we've decided are the insurance plan for you as an individual and for workers as a company. And so that it plays a really important role in shaping choices. And then regulators, in many cases, and varying state to state and federal plans versus non-ERISA plans, are kind of all off doing their own thing. And so we've got a lot of complexity in how these prices are set, and a lot of places where things can happen. And depending on your point of view, things can go wrong and influence how prices are set. And so we end up with situations like this. This chart was in the New York Times a couple years ago using data from the Healthcare Cost Institute, which is a collection of large insurers that pool data for this organization. And this figure shows prices, and this is the negotiated price for commercially insured populations for a metabolic lab test panel in the year 2016. This metabolic panel, I'm not a clinician, but this is like the commodity service in healthcare. So the way it works is you get a blood draw, somebody puts it in the machine, and that machine analyzes and tells you your clinical values, analyzes your blood. That process is exactly the same anywhere you get care. And this is, it's not a surgery where, some providers are better than others. This, again, is the commodity service in healthcare. And despite what we think, if it is a commodity, we should have close to single prices or less range in prices. We just see that prices are really all over the place. And so if we look at places like Miami or San Francisco, prices range from about $100 up to the upper end in Miami, over $700. So that's a pretty large range in prices for something that, again, is pretty common and pretty easy to do. In places like Baltimore and Portland, the range is tiny, from about $15 or $20 to just under $50. And so it's really hard to think, this is the one service in healthcare where we shouldn't see this type of price variation, and the level of variation we see is just crazy. And it's hard to say, what's the economic model and why a lab test in Miami or Houston is so much more expensive and also ranges so much more in price than in other markets. And so this is, what a lot of economists have spent the last several years doing, is trying to understand what really drives these prices. And I'll talk a minute on what we kind of have concluded. It's not just these commodity services like lab tests. If we look at other work from Zach Cooper and team on using very similar data on prices for a much more complex procedure, leg MRI procedure, so a little bit more complex, but not a ton, we see kind of the same level of variation. Again, a large range in prices, both across markets, but also within markets. And so, for example, if we look at the bottom right-hand corner for Houston, we see that prices range for this MRI service from about $500 all the way up to $3,000. And again, this is not a surgery. This is, you go in a machine and you get an MRI, and that machine is more or less the same, regardless if you're going to the $500 or $3,000 price procedure or provider rather. And this is also adjusted for things like maybe some patients are sicker. That's probably not going to influence your MRI price, but maybe. And so this is kind of our best attempt to say, this is an apples to apples comparison. And then in some of my work, we've actually looked at variation in hospital prices across the country using data from employer plans in state all-payer claims databases. And what we find is, again, the same levels of variation for these other two services, or the previous two services, but these are maybe a little bit more complicated. It's probably harder to run a hospital in some markets than others, but we still see a huge range in prices. So relative to Medicare, which again, which does adjust for things like it costs more to hire doctors and nurses in one area versus another area, we see that prices on average are about 250%. So employers are paying about 1.5 times above what Medicare pays. And there's also a large amount of variation. So in some states like Hawaii, Arkansas, and Washington, employer plans are paying about 150% of what Medicare pays. In other states like Florida, West Virginia, and South Carolina, the price is about double, about 300% of what Medicare pays. So, hospitals in Seattle are able to stay in business and operate at a rate that is about half what hospitals in Tampa are getting paid. And so this is a conundrum for the healthcare system of why we have so much variation and what can be done about it, and whether or not we think this variation is warranted. That kind of question of warranted is a economic as well as a societal question. And then the final point is we also see lots of variation, not just across markets, but also across different services, or sites of care, rather. And so extending what Ellie talked about on the kind of hypothetical choice of prices for getting a colonoscopy, this uses data from the California Public Employees Retirement System, basically all state of California and municipality workers and their employee benefit plan. CalPERS is large. It's after the federal government, the second largest purchaser of healthcare benefits in the country, with now about 1.5 million covered lives. So following the last recession that we had, CalPERS in the state of California was about to go out of business and needed to cut costs and figure out how to do it. The state of California and CalPERS said, we want to do a high deductible plan. Their union said, that's not going to be great because we know that that's going to be pain for everyone. And we want CalPERS, is our leadership to do something different. And so CalPERS kind of went back to the drawing board and then came up with essentially this chart. Colonoscopies are a fairly common service, moderately complex, but not something that's requiring multiple days in the hospital. And what CalPERS found was that if we look at the red dots for hospital outpatient departments, prices range from a few $100s up to almost $10,000. So for hospitals, that's a tremendous range in price. The average price for a hospital was around $3,000 to get a colonoscopy. Prices for the blue dots are ranging from, again, almost the same level range from 100 or a couple hundred to about 10,000, but the average price was about $700 to get a colonoscopy in an ambulatory surgical center. And so price variation exists not just across markets, and this is using data from the state of California, but also across sites of care. What CalPERS decided in the reference pricing program that Ellie discussed is we're going to have a reference price to get patients to not go to the $10,000 hospital and get them to go to the $1,000 provider. But what CalPERS also realized, in the spirit of keeping things simple, is that ASCs are so much cheaper. And so instead of having this complicated program where we're going to say this is the tier that a provider get your colonoscopy is on, why don't we just tell patients, go to an ASC and just be done with it? And so under the reference pricing program for CalPERS, it actually only applies if you go to a hospital. But if you go to an ASC, because prices are so much cheaper, there's no reference pricing or cost sharing applied. And so that's kind of a default to make the program easier to understand. But these types of programs have been quite effective in driving costs, and I'll talk about that later as we go. And so the level of price variation in the range of prices is a curiosity for researchers. And there's been lots of really great work in the last couple of years to try and really understand what drives prices, and in some sense, are we getting what we're paying for? There are really kind of three factors, or three hypotheses that potentially explain what drives prices. The one is just the fact that providers who have lots of essentially patients without private insurance, so whether this is Medicare, Medicaid, or charity care patients, are essentially so underpaid by those providers that those payers, rather, those providers have no choice but to charge high prices to patients with private insurance. This is the cost shifting argument. There's been a lot of really good work over the last 10 or so years looking at whether or not this cost shifting argument is valid. And basically the conclusion is absolutely not. And if anything, it goes the other way around, because in that kind of complicated negotiation model that we had before, the way that you as a hospital are able to charge high prices is essentially you want to be a highly valued provider for rich patients. And so it actually behooves you as a provider to charge higher prices, or if you have lots of privately insured patients and wealthy patients, then you actually get to charge higher prices, and much more so than if you had lots of Medicaid or were a safety net provider. Other hypotheses are, that look, we're getting what we pay for, and if we're paying high prices but getting better quality, then maybe that's actually a good thing, and maybe we should actually not focus on the high end, but we should focus on the low end and ask why they're not having great quality. There have been a numerous number of studies that have looked at this question and really find that maybe there's a little bit of relationship between price and quality, but it's pretty small and modest and not nearly enough to drive the huge range in prices. Where we do find a lot of explanation is when we look at things like market power and market structure. So if you're a provider that's a dominant market position, whether that's because you're in a market that only supports say one hospital, or because you've gone out and acquired other hospitals or acquired physician groups to feed into your hospital, then that's something that really drives prices and is a strong contributor to why we see such high and variable prices in the country. But price variation exists in many other markets. So if you go to anywhere in town, you could go buy a fancy car, or you could go buy a less fancy car. The prices will be 2 to 3 to who knows how many times higher. If you go to one car lot, they'll have a different price than another car lot. But we're not all gathered here to talk about why we should be concerned about automobile price variation and affordability for automobiles, even though we have a tremendous amount of variation. And so what's different about healthcare, and why should we think about these questions uniquely in the context of healthcare? This really goes back to the seminal paper by Ken Arrow in the 1960s, and how we should think about healthcare markets. So there are really kind of 3 distinguishing features about healthcare that really influence why we should think about prices, and why we should be much more concerned about prices in healthcare than in other markets. So first, there's really no information on prices on healthcare services, and that's really what I'm going to talk about today. And then 2, even if you had information about healthcare and really knew every single price, if your insurance company is going to pay for most of the service, or indirectly if you have employer-sponsored insurance, your coworkers are subsidizing your care decisions, then why as a patient should you really care about prices, and why should you even shop? And that ties in really greatly to Ellie's talk. And then finally, even if you have information, you have incentives to go to different providers and really want to be an engaged shopper. If there are only a handful of hospitals or physician groups in town, then you really have no choice where you go, and your care decisions are being made for you. I think this is especially true if you're, say, needing a referral and you're trying to, say, get an MRI, and your primary care doctor works for a hospital system, which about 70% of doctors now do. Then in that case, guess what? You're going to go to the hospital, and it doesn't matter how much you want to shop, because in order for you to shop, when your provider is telling you, look, I work for this hospital system, I want you to get your MRI, your lab test, or your colonoscopy at this hospital system, you have to tell your doctor, I, as a patient, know where I should go more than you, and my medical knowledge as a patient is better than your medical knowledge, and so I'm going to tell you you're wrong and tell me where I should go shop. And so there are a lot of fundamental differences about healthcare, and that's led to really kind of 3 policy options that are kind of floating around on the policy window to address each of these kind of unique differences about healthcare. So the first is thinking about price transparency, and recognizing that prices are really largely unknown and trying to do something about that. The second is actually giving patients incentives to shop. This is really building on transparency. And then finally, recognizing that even if patients do want to be good shoppers and have all the incentives, if they don't have access to competition and other types of markets, then maybe we need to think about regulating prices. one way I kind of think of this is kind of the Goldilocks menu, where from a savings perspective, it goes, easy, medium, or high. But then also from an implementation standpoint, it's likewise. It's much easier to do price transparency. This is kind of a low-hanging fruit for policy. But as I'll talk about, we're going to get maybe modest effects from price transparency. Thinking about benefit design and how patients have incentive to shop is a little bit harder, but we'll get better savings. And then maybe where we'll get our most bang for our buck is thinking about regulation and policies around prices. But again, this is going to be much harder to do. One important piece of this pie, though, is that if we think how these policies would overlay, it's not that they're totally separate. If we want to, say, implement benefit design choices or regulation, we need to know prices. And so price transparency, maybe one way to think of it is really kind of the hub that potentially would enable all these other policy options. And the push from or for price transparency, I think, really comes from a lot of the recognition of how impossible it is for patients, as well as frankly providers, to get information on prices. One of my favorite studies is here. This is the main result, and this was actually somebody's. It was her high school project, and so I'm not sure what you guys were doing in your junior year of high school, but this person was writing papers in JAMA, and what she did for her summer project was she called up 20 hospitals in the Philadelphia area and asked them 2 questions. So one, I need an electrocardiogram, again, a standard medical procedure. Every single hospital in the country does this every single day. And I want to know how much it costs. And just to kind of make it easy, she said, look, it's actually not for me, it's for my parents. They don't have insurance, so we don't need to worry about, benefit design or kind of what's the price between different insurers. Just give me your rack rate, and that's what we'll pay. The second question she asked was, how much does it cost to park? Hospitals, they do parking, but we typically don't think that that's the kind of core mission of a hospital. And out of the 20 hospitals, 3 could give prices for an ECG, with the price ranging between $137 and $1,200. That seems pretty large variation. And again, these are all in the same market. But when it came to parking, all but 1 hospital knew exactly how much was to park, and the price ranged from free to what I think are pretty complicated measures of prices or price menus, so $3 for an hour, $5 after that. And so for the things that the hospitals do, they had no idea how much it cost. For the things that is part of just going to the hospital, hospitals knew exactly how much it cost. And so this has led to a policy solution of, let's try and fix that. One example is some of these newer price transparency consumer-facing tools. And so this is a screenshot from a tool that I've worked with and evaluated and done some work with. And here, rather than the kind of we don't know the price, this is actually pretty detailed information for people or for patients who want to get an MRI of their lower back. Here with contrast, and this is for the San Francisco area. This tool is actually tied to your claims data and your benefit design information. So they know that this person is on a high deductible plan. So for these first 3, because this person has not met their deductible yet, they're actually going to be paying the entirety of costs, which range. This is just the first 3, but you can filter and do kind of all the stuff we do every day on tools like Yelp, and actually find the MRI provider that works best for you. And so this seems like a really detailed information. If this is going to be anything that changes how patients are consuming care, it's going to be this type of information. And this is just for MRIs, but for really any shoppable service, you can actually use these type of tools to look very granularly at prices, as well as in many cases look at quality information. That is a single tool, but actually most patients have access to that type of information. So this is a slide from my colleague Chapin White, just kind of looking nationally at what share of patients have access to some type of price transparency information. Typically, these are actually provided not through these third-party tools developed by or through your employer, but actually developed directly through your insurance company, and so that the pricing information in these tools and these price transparency tools should be pretty accurate. And so, essentially, some of the early tools that people had access to were probably a little bit spotty. But right now, everyone has access to a price transparency tool, or rather, everyone with private insurance has access to some type of price transparency information through their employer. So, this should be great for the healthcare system, and a lot of that, variation in prices that we talked about earlier, we shouldn't see now that patients are actually shopping. And a big reason to kind of think on why this might be is that this quote from a Harvard Business School professor, that when consumers apply pressure on an industry, whether it's retail, banking, cars, or computers, it invariably produces a surge of innovation that increases productivity, reduces prices, improves quality, and expands choices. So that is where we should be in healthcare, right? So I should save the time and we can have early lunch. But that's not quite actually what we've seen. So in some of the work where we've actually looked at some of these tools, what we find is that for services like lab tests and advanced imaging, patients who do shop actually do seem to be saving quite a bit. So for lab tests, the savings rate for shopping is about 15 or so percent. For imaging, it's around 10%. And for physician offices, a lot less range in prices. There's about a 1% difference in prices between those who shop and those who don't. The challenge is that while there are patients who are using these tools to shop, essentially nobody's actually using these tools, even though they're ubiquitous and everyone has access to some type of price transparency. And so if we look at overall savings, if we add up the kind of number of shoppers and the people who are actually, in the savings rate from shopping, we don't find any kind of noticeable difference in spending. And so we don't seem to be producing that surge of innovation that's improving quality and reducing costs. In other work by Sunita Desai and others that actually looked at the, again, the CalPERS experience in implementing this price transparency tool, they found that about 12 or so percent of the patients by almost 2 years in or a year and a half in actually logged in and maybe poked around. And that leaves the 88% who don't even know their login and never even touch the tool. The people who go a little bit beyond just kind of logging in and creating an account and kind of poking around and actually search a whole 2 times was about 4%, and then the number of people who search 3 times, so this is the kind of the most actively engaged people in this population, was a whole 2%. And so very, very, very low rates of use, even though we know that there's lots of variation in prices, and this should be a way for patients to save money. And so if we look at just kind of the net effect, what they did is they looked at the CalPERS population on the top in the orange and a control group population with the same insurance benefit design and networks on the bottom, and just looked at trends in overall spending before and after the tool went into effect. And these lines were basically the same before the tool went in, and they're basically the same once the tool goes in. And so it doesn't seem to be any like there's any kind of role in price shopping in reducing spending. But that's largely going to change. And so the policy community has not seen this information on price transparency's impacts and said, we're going to call it a day. The kind of role of price transparency in the healthcare system in the last several years has actually really, really greatly increased. This is largely due to an executive order from the Trump administration a couple of years ago that has 2 key components on price transparency. So first, going in effect in January 2021, hospitals are required to post shoppable or post negotiated rates for 300 shoppable services. And then secondly, when going into effect about a year ago, insurers are required to post not just 300 rates, but actually their entire set of negotiated rates. And so this is kind of, especially the insurer data, the mother lode of price transparency data. And so how has it gone? Well, on the one hand, the hospital posted price data, hasn't been that great. So CMS decided that the penalties for noncompliance were going to be pretty minimal. So at least in the first wave, it was about $100,000 per year for noncompliance, which for the academic centers, a couple blocks away from here is like 12 minutes of revenue. And maybe not surprisingly, at least in the first wave, no hospitals actually, or very few actually posted prices. Now, about 2 years in, about 25% of hospitals are fully compliant. The penalties have gone up a little bit, but again, not a whole lot. And I think CMS has only penalized about 4 hospitals for noncompliance. And so, don't take it from me, take it from rapper Fat Joe, that hospitals are largely ignoring this policy. And then the other point of data is the insurer data, which has almost the opposite problem, that here insurers posted absolutely everything, even services that aren't actually being billed. And so the data sizes in the files here are pretty massive and unwieldy. So if we just look at the combined data size of all the national rates, it's over a petabyte, which is orders of magnitude larger than anything posted in the Library of Congress. I think this is actually, one statistic I've heard is that it's larger than the entire catalog of Netflix. And so for the research community, this is just a huge amount of data. But it is useful, and so in one study that's forthcoming, we've actually been able to pull through a pretty big process prices for Humana and look at prices across the country by linking with claims data. And here what we find is again kind of the similar story, where prices vary quite considerably across different markets. So we see some areas like the Midwest area where physician rates are pretty high. Areas like Florida, where there's lots of physicians and lots of competition among physicians, physician rates tend to be quite a bit lower. We can also use the data to look at prices across different markets, and so this is not Humana. This is actually the full set of large insurers across the country. One of the things we find is that if we just look at knee replacement prices, so relatively complex, we find prices range from about $12,000 up to about $32,000. So 3x range in joint replacement prices just in Houston. The Harris Health System, I believe, is the safety net provider. So lots of Medicaid providers. So that's certainly not consistent with them having the lowest price and lots of uninsured patients of cost shifting. And Houston Methodist Baytown is towards the top at about $30,000. We can also use these types of data to look not just at price ranges across the country or within a market, but within different insurers. So here I have prices for, again, knee replacements for Memorial Hermann, as well as Texas Orthopedic, and by the major insurers that they have negotiated prices with. And so we see is that prices for Aetna, Blue Cross, and Cigna, regardless of the provider, tend to be about the same, around $20,000 or so. The kind of real difference is prices for Humana and United, where for Memorial Hermann, prices are around $60,000 for Humana and about $30,000 for United. But then they actually almost flip when we go to Texas Orthopedic, and about $30,000 for Humana, and almost $50,000 for United. And so one kind of potential use of these types of data is to understand what is the kind of contracting mechanism for why these two different insurers have almost the exact opposite prices for these two different hospitals for joint replacement procedures. And so just to wrap up in the last couple of minutes, there's lots of new data, and so there are a couple of kind of ways that this data might be useful. So first, maybe we want to have a kind of round 2.0 for the patient shopping tools. As I talked about earlier, we can have the best information on prices for patients, but that doesn't do anything to improve the patient incentives for getting care or the market or regulatory dynamics for prices those patients face. And so it's probably not going to be a lot of juice from that squeeze. The other way that this could be used is to motivate a lot of the purchasing decisions and benefit design decisions for employers. So I highlighted the slide earlier from CalPERS. That required a lot of infrastructure from CalPERS. And now with all this data out there, it's potentially possible that any employer can have that same type of insight. And we can also use the data to inform markets and regulatory policy and make sure that we're actually have good data on prices and can actually make sure that the markets are competitive. Am I at time? All right. So, go the other way. And so just to, I guess, kind of highlight the last point on we've talked a lot about benefit design, but I think one important use of transparency is essentially to help employers audit the negotiations that are happening behind the scenes between their insurers and providers. And many of these negotiations are rife with conflicts of interest. And a lot of this new price transparency data can really, I think, help employers see what's going on under the hood. Just to highlight one example, in some of the work that we've done, we were actually able to get data, claims data from many employers in Indiana, and highlighted price variation for hospital care using the study that I talked about earlier. And one of the kind of notable things is that there's a particular healthcare system called Parkview Health, which had the most expensive prices in the country, and relative to Medicare, it was around 400% on average. And so the employers saw that, and it got lots of attention, and essentially went back to their insurer and said, why are you out there negotiating what are the worst prices for healthcare in the entire world, and we're paying you a monthly fee to do that. And if you don't actually do something better now that we have this type of information, we're actually going to find a different insurer or go somewhere else. And so having that insight into those price negotiation processes, I think is one area that we haven't really thought about in terms of how healthcare purchasing decisions are made, where we can actually lead to get better prices. And so kind of the end result of this dynamic was that there's a new contract between this hospital system and the insurer that's going to save about $600 million over a 5-year period. And so there's a lot of, I think, room here to implement these types, or at least have these types of insights. So I'm well out of time, and so happy to turn it over for questions.
Thanks, Chris. That's fabulous. And full disclosure, with the Houston Business Coalition on Health, have been working with Chris on a lot of this transparency stuff. So, I think there's lots of opportunities for employers and policy people to use this data much more so than at the individual consumer level, as you point out. It's just, there's tens of thousands of prices, and it's impossible for consumers. But one of the concerns I've heard people raise again this week to me in a conversation was that this transparency stuff is actually going to backfire on us who are trying to lower prices or make prices more rational, and hospitals will just raise their prices, or other providers will raise their prices. Have you heard much about that in terms of the concern about sort of the potential negative side of all the transparency?
Yeah, so I guess if I could show one slide. One concern is that essentially the lower price providers will see that they're lower price, and maybe they didn't know that before, and go back to the insurer and say, I want what the provider across town is getting. And that would potentially, raise prices, and we should think about that. I think that there's two important things to think about that. So one is going to be how effective are insurers in negotiating prices, And so if a provider says, look, we want to get a higher price, there's a reason that low-price providers are lower priced, and that's because patients don't want to go there as much. And so a strong negotiating insurer should say that, well, if you want to get a higher price, you've got to improve your quality, or you got to get us, make us want to have you in our network, or if we kick you out, we're going to have pushback. The other, I think, important consideration is just, I think a lot of providers actually know prices pretty well already. And so there's a lot of, market intelligence firms that, essentially collect claims data and sell it back to providers when they're doing price negotiations. And so I think, even in the absence of the federal price transparency data, a lot of providers pretty well know their place in the market.
On the price transparency tool impact on cost, was there any study that was done that could show the impact of health plan choices that patients were making or members were making, like high cost, high deductible plans versus HMO PPO, or was it just a general study that was done?
That's not an area I've looked at. There have been a few areas that, studies have looked at this and, shown that patients aren't that great at choosing plans, as Ellie mentioned, and having some type of information, especially when it's a default, this is the best plan for you, can help a little bit.
Thank you.
Just curious how much, so when we say prices, there's obviously like list and retail versus negotiated net. I'm just curious how much, how are we accounting for some of the rebates and the incentives that a lot of the negotiated contracts have with the actual net price versus just what's on people's website? How accurate do we think these prices are?
That's a good question. So, this is on medical services, and so there's, not nearly the extent of rebates that we have to worry about on the drug services that Stacey will talk about. But at the same time, there are additional payments. So many hospitals have a renegotiation fee that some insurers or brokers have to pay to kind of even up or open up negotiations, and that is there's no insight anywhere, at least that I know of, on that type of data.
Not into healthcare industry, but my question is in the commodity types, you show Florida was most expensive. Is there something, a correlation between government policies that makes that particular state very expensive? Especially if you see correlation between education cost and government subsidies. It's very high. So is there a fact on that? My second question is, for every $100 spent, can you tell me how much it goes to the provider and how much of it stays with the insurer, I guess?
Yeah. So on the first question, so other people have looked at relationships between income, education levels on the patient side, and there's not really great relationships. It's really driven by market structure forces. The second question is that's a big question. In general, the insurer retention is, 5-ish% of, I think, total spending. And in terms of healthcare spending, clinicians are about 15 or so percent. Hospitals, again, are about 40 to 45%. But then a big question is, what are the insurer incentives to keep the pie growing? So if you're getting 5% of a bigger pie, then that's maybe an incentive to not kind of put the damp down on healthcare cost growth.
Here we go. Thank you. I think it was Ken who asked about converging upward rather than converging downward when price transparency kicks in. What little evidence we have on this in the healthcare market does not suggest that this will happen. So to Chris's earlier point that most providers have at least some sense of where they are in the price distribution already. I have an early stage study that looks at a price transparency tool that was released by New Hampshire several years before the Trump administration's changes. And we just see very little movement in overall prices. You know, there's sort of shifts at the margin, particularly for services that patients are likely to look up, but the overall price distribution changes very little.
So one of the craziest things in healthcare pricing to me was actually shown on your little chart, that the prices sort of go like this, and then there's this giant tail, which is those very few people that end up paying bill charges or paying based on the charge master. And so you still have this situation in all the hospitals and almost all the doctor's offices where they have their bill charges are, 8, 10, 12 times what they accept from Medicare. And it just seems like that's so silly. It's like, is there any effort at all or any way to at least chop off the tail at the end of the crazy prices? I will say that I know for a fact, because of insider knowledge, Harris Health was down at the very bottom of your Houston chart, and that's because they actually don't have that weird tail. They really, basically, they set their charge master at essentially the Medicare prices, and because they're a public hospital and they're not there to, anybody that pays them they like, right? It's anything that's not charity care. And so it seems like there's a real opportunity from a PR standpoint for medical providers to get rid of those crazy list prices that they have. Or is there any reason for that to continue to exist in the system?
Yeah, so to be clear, that chart, that tail, that wasn't the list price, that was the actual in-network negotiated price.
Well, that just says they have that deal, because there are rental networks that have a 10% discount and stuff like that.
Yeah.
Still exists, and it's based, but those are all based on this chart of not a flat price.
Right. So the way I kind of think about those extreme outliers is kind of similar to this Parkview example, where there's kind of a sweet spot for the areas that are really driving healthcare spending. And so Parkview is in Fort Wayne, Indiana, which is kind of this somewhat geographically isolated area. It's 2 hours away from Indianapolis, Cleveland, Detroit, and Chicago all at once. And so it's kind of relatively constrained. And just kind of over the years, this Parkview system has accumulated a 55% market share, with the rest essentially being by a safety net provider. And so you're in a decently sized market of 600,000 or 750,000 people, and you're essentially the only game in town, and you can just kind of charge whatever you want, and that's what we see. And so that's where if we have kind of, no matter how much price transparency data do we have, that's not going to fix that fundamental market issue. But if we have price transparency data, then we can say, look, this is the problem spot, and we need to have some type of regulatory policy to address these types of markets.
Just an anecdotal comment about imaging, and then a question. So people talk about imaging being relatively homogeneous, but from my own experience in cancer, I was trying to get into Baylor College of Medicine to do the CT scan as quickly as possible, because I had a rapidly growing tumor, and I had to wait. So I just went to like a second tier place where they could take me right away, and then it turns out, so what they did is they ended up with a blurred image, which actually helped me, because then because it was blurred, it looked as though the cancer had spread. And so then when an MD Anderson surgeon saw it, he says, "Oh, we've got to operate immediately." So I jumped to the front of the list, the line. And then now I go back every year to have a a brain MRI, brain and head and neck MRI. And so I have to go for, my last time once every year for 5 years. My surgeon has moved to Baylor, but he still insists that I go and spend $4,000 to get the MRI at MD Anderson, because it's the person who reads the MRI that's most important. And it drives me nuts, because I feel like that person is the one I really want to pay for. I don't think he's getting rewarded. It's MD Anderson that's collecting the revenue.
That's right. So the chart that I showed earlier, that is the MRI kind of just for putting you in the machine. There's a different fee for actually reading the image. And that's where I think we need to think about, especially, vertical and health system relationships in healthcare, in what's the ability of your MD Anderson radiologist to read a MRI that doesn't come from MD Anderson, and are there restrictions that are placed on your provider by his employer or his or her employer on taking in places from outside the walls of MD Anderson?
Yeah. And so my question is, when you're implementing, when you work with CalPERS on the reference pricing, I mean, even the thought of how do you explain to the workers you can only go to an ambulatory surgery center and not a hospital outpatient department, when they don't even know the difference? You just get pushback. What do you mean you can't tell me I can't go to that facility across the street? It looks exactly, it looks inexpensive.
Yeah. So I think this is a kind of like a organizational kind of cohesiveness story. So in CalPERS, it wasn't, CalPERS is a benefit plan design leader who was out saying what the story was, or what the program was, or even really designing it. It was really the labor unions. And so, CalPERS as a leadership group wanted to do a high deductible plan, and the labor unions said, we don't want that. We want something more targeted. And then the kind of agreement with CalPERS leadership was then, okay, labor unions, you have to go out and make sure people are understanding the policy, and if it doesn't work, we're going to do a high deductible plan. And so that's a unique employer arrangement. But in other cases, it has to be something that the employee population has buy-in, and feels some sort of, at least recognizes some trade-off and benefit we're doing, whether it's reference pricing or tiered or narrow networks.
Yeah, and that's related to this issue. You mentioned there's large potential cost savings with diagnostic imaging and lab tests, but it's just so hard, because I feel like so many providers are providing that all in-house. You go see your PCP and and just go down the hallway to have all the tests run so that we can collect the revenues.
Yeah, I mean, so if your physician works for a hospital system, regardless of whether or not you have reference pricing or narrow network or whatever, you're going to get your tests and your services done in the hospital system, and it's going to be more expensive. And that's true in Medicare as well as commercial payments.
Okay. Any other questions?
I just wanted to add that what I think we've just been discussing here is a major limitation to one of the ways in which we as economists actually study some of our healthcare delivery. And we look at this very single tangible item, an MRI or a CBC or an office visit, and we think that we can glean a lot of information about transparency or market share around this one little thing. But if you remember, every one of these systems has when you go to an office visit or you go to a hospital, there are lots of things happening. If you look at a claim, there's hundreds of little individual actions that are each billable. And so when we consider price transparency at a very singular level, we are missing so much of the interactions. That's not to disclaim anybody's, but it might be a part of why some of our ideas around how we limit prices or limit healthcare costs don't actually function, because we're not adding enough complexity to our models about the reality of how healthcare is delivered. And so I just want to keep us thinking about just what we've brought up. if you have had an MRI in one system, all of that system is attached to an electronic health record, which is the easiest way for the physician to see it. It's the easiest way for the radiologist to read it. And so that whole system functions as an entity. It's not the MRI itself. So that may appear within one particular CPT code, but that doesn't necessarily mean that that's the entirety of the story. So we just really have to add these levels into our models, which is really hard.
But there are some that are starting to do episodes, right? So you can look at price transparency from an episode of care that gets the physician and the radiology and the facility.
Yeah.
Yeah, it's hard.
Right. So maybe there's two approaches. It's almost the whack-a-mole. If you do something for lab tests, you do something for imaging, you do something for cancer screening and all that, and that becomes hard for patients and just everyone to monitor. Another approach that some large and especially state employee plans have done is said, we're just going to do not say like reference pricing service by service. We're going to do across the board a percent of Medicare, say reference price. And so, for example, the state of Montana employee plans, state of Oregon, and the state of North Carolina tried but didn't quite get there, said that. So we're just going to have a flat price, and we're not going to worry about this kind of episode or procedure level differences, because everything as a whole is reference priced. And that's the real teeth. And it's like state of Oregon in 2 years saved $100 million just on outpatient services for that.
Okay, well, thanks very much. We're going to have a break for lunch. There are box lunches out in the lobby area, and we'll come back at 12:20 and feel free to bring your lunch back in to listen to our next speaker at 12:20. Thanks. It looks like everyone has had a chance to get their lunch, so we'll go ahead and start with our final speaker, who's also our keynote speaker since it's lunchtime. We're delighted to have Dr. Stacy Dusetzina speaking with us about drug prices today. Dr. Dusetzina is, we had a great conversation yesterday. She's on last night at dinner. She's on the Medicare Payment Advisory Commission, which you may not have heard of before, MedPAC, but it really is responsible for making recommendations to Congress about just about everything having to do with Medicare, not just reimbursement, but access and how to set up plans. So that was fascinating. But if you also look in Google Scholar at Dr. Dusetzina's CV, you'll see just how much experience she has had in terms of publishing and doing research on all different types of drugs, specializing in oncology drugs, but certainly a wider range than that. And if you listen to NPR, you'll see that she is one of the go-to people talking about drug prices, particularly what's happened in terms of changes in policy due to the Inflation Reduction Act. So with that, Dr. Dusetzina.
Thank you so much. It's really great to be here, and thanks for hanging in there. I'm glad everybody has gotten their lunch, and I scarfed some down, so I'm ready to go. I'm going to talk about prescription drug affordability, and I'll say that having worked in this space for quite some time now, I always felt like I needed to bring a therapy dog with me to these talks because it's so depressing. But there's good news. So we're going to end today on a high note when it comes to thinking about some improvements in affordability that are coming. And I'm going to center most of my comments around the Medicare program. So just to give a little bit of a roadmap, I'm going to talk first about prescription drug prices in the US and how they're set. Give you some specific examples of some problems over time with policies around coverage, particularly in Medicare Part D, the prescription drug benefit for seniors, and then talk about what's coming with the Inflation Reduction Act. So I think the first part to know is that in the prescription drug market, prices are set at what the market will bear. And I I think that what this basically means is that there is a lot of negotiation that happens in price competition when there are head-to-head competitors for drugs. So if you could choose between a set of drugs, you can imagine that the prices can be really aggressively negotiated by pharmacy benefits managers and payers. So prices are really related to competition here. But there are also a lot of constraints that happen in this market that make us think it works more like this. So we have some huge outliers. We have these really bad actors. We have venture capitalists who buy up cheap generic drugs and then overprice them so people can't afford them. And we also have some specific problems around benefit designs when we have rare disease drugs, drugs with no competitors, or drugs that have required coverage, which is the case for cancer drugs, which will be part of the topic today. So when you think about drug prices overall, there's kind of this list price, net price difference. And the literature here can be sort of confusing because often you don't know what price people are talking about. And I think probably until about 5 years ago, people would just use the list price and not really acknowledge the fact that there was a lot of negotiation, discounts, rebates that happened. That meant that when we talk about drug prices, we might not be talking about the real price. So this is an example of changes in the list price versus changes in the net price for brand name drugs over time in the US. But this is also complicated in the fact that this is kind of overall, but we have some areas where there aren't negotiations really occurring for brand name drugs. So this again varies by price competition that varies based on how many competitors are in the market and what are the rules for formulary coverage. And we'll dive a little bit more into that. So I'd like to present this as an incredibly simple system that has no real challenges. That is sarcasm if you aren't picking up on the inflection. This system is a mess. There is, on purpose, no real transparency within the system, and there are a lot of different actors within the supply chain. So I thought about, okay, well, how do I break this down for the audience? And I think if you want to think about this system, it's not even just this bad. It's more like this. So it's a labyrinth of actors within the system. It is a lack of transparency on who's getting paid what. And we also know that there are other factors that are driving up prices and overpayments even within the system. So for example, we've heard a little bit about vertical integration. There are vertical integration of plans and PBMs, pharmacy benefits managers that negotiate, and they also own pharmacies. So there's a lot of questions I think that are fair about what we're paying for drugs, and not a lot of great answers for how to think about regulation here that would actually work. Because to regulate, I think you actually need to know how the system is working today and where the overpayments maybe are occurring. But without that transparency, it's hard to make good policy. So I think it's also important, just as a level setting, is to think about what we pay relative to our peers. And you heard this from John Gruber this morning. We pay more than pretty much everyone else, other countries. And this is an example for Ozempic. I am guessing if you have a television, you've heard an ad for Wegovy, or in the last, not recently, because there's a drug shortage because so many people want Wegovy. So this is where we are with this. These are drugs that are being approved for weight loss indications and for obesity use. They are super high in demand, but you can see if you look at the price per month of treatment in the US relative to our peers, someone very astutely pointed out, you could actually buy a plane ticket to fly to France, pick up your drug every month, and it would be cheaper for you than if you just paid that cash price at a pharmacy. And they gave the example of in Indiana. Think about that. Round trip ticket to France. Although I do hear there's a bed bug situation, so maybe choose a different country for the next little while. So we're number one. Okay. So I want to switch gears a little bit and talk about specific affordability issues that have been a concern in Medicare Part D, the prescription drug benefit, and I'm going to be focusing this on cancer drugs. The reason I think these are a good example are they're really expensive. They also are really important for people when we think about why you want to have health insurance. It's to be able to afford something like this if you need it. And I'll also say that there's a tremendous range of value here for cancer drugs. So some of them don't really present good value for money. I am centering these remarks as though we think they're worth paying for. So most of my examples are going to be drugs like Gleevec, which are basically best drug ever for cancer. So practically a curative therapy and was the highest priced drug at its outset. But we're going to keep this type of example in mind. We could probably get into some conversations about value at the end later, because that's not always a set. But let's just dive into some of these pricing challenges. So this is an example of new drug prices over time. So these are the prices that are being passed through at the point of sale on Medicare Part D formularies at the years when these drugs were first coming onto the market. So each bar represents the drugs that are first coming into the market in that year. So we usually have about 2 or 3 new cancer drugs in this space. And what we look at, and we inflation adjust this, so we should have, level bars unless prices are going up, but prices are going up. So for new orally administered cancer drugs offered under Medicare Part D, we see that their prices per month, this is a per month amount, are about $8,000, a little bit less in 2010. And then we've pretty much doubled that by 2018. And I'll tell you, things have not slowed down. Now we're talking more in the $20,000 range per month for drugs that are being approved for use in cancer. These bars represent a slightly different concept. So each of these bars represent the 13 cancer drugs that were available in each year of the study period. So no new drugs being added here. This is just the drugs that were available the whole time, and their price increases. And in general, we found that they go up at least 5.5% above inflation each year, regardless. This is not like new innovation, same drug. So we have both this new drugs are getting higher and higher prices set, and existing drugs are having prices increase. These are important concerns because we have to think about how Medicare beneficiaries are able to afford to fill these drugs. So that brings us to Medicare Part D, which is near and dear to my heart, but boy, has had its own share of problems since its outset. So I want to tell you a little bit about Medicare Part D's benefit design and how it has changed over time. And some of the ways I think we thought we fixed affordability problems in Medicare Part D previously, but that left high spenders or people needing high-priced drugs out. So I will say that this benefit is not easy to describe. So it is, I've left off a part of this, if you could even imagine that, but there's sometimes a deductible. So we're just gonna ignore the fact that there's sometimes a deductible, because deductibles in Medicare Part D are usually maybe $100 for the drug benefit, could go up to over $500 now on some plans, but we're just gonna ignore that and assume you picked a plan without a deductible. So when Part D started in 2006, we basically had a situation where patients paid roughly the equivalent of 25% of their drug's cost until they hit the coverage gap or the donut hole. So the way you hit this is you spend a couple $1,000s in total drug spending between what you and your health plan are paying. So a lot of people hit the donut hole. And what happened when you hit the donut hole is you have to pay 100% of your drug's price at that point. You can see the problem here, right? So what happened in early research showed that basically people would go ahead and they'd be filling their prescription drugs to manage their chronic conditions, and suddenly they got hit with the full price of the drug, and everybody stopped taking them. So there's this interesting set of papers that basically show that in October and November, everybody stops taking their medicine, and then they start taking it in January when their benefits reset and their price drops again. So we knew for a long time, basically right after this started, that this plan was not really working well for the average person, and especially for people who need brand name drugs. because prices for even kind of lower priced brand name drugs tend to be $400 a month, $500 a month if you were paying full price. So that would be like if you're filling in insulin or a newer anticoagulant. So not a cancer drug. Cancer drug's much worse. I will show you. The other thing to note is that after you go through the coverage gap, if you have high enough spending to reach the Medicare's catastrophic phase, you pay 5% of your drug's cost, which, back in 2003 when this policy was passed, most drugs didn't have prices that were that high, so 5% of the drug's cost probably sounded like a pretty good deal for most drugs. So then we enter the Affordable Care Act era, and we close the donut hole. So what happened here is with the Affordable Care Act, the donut hole was slowly closed between like 100% out of pocket to 25% out of pocket today. That got accelerated a little bit with the Bipartisan Budget Act, where they accelerated the closure, so it closed 1 year earlier than expected through the Affordable Care Act. But basically, you go from owing 25% or a copay, a lot of plans use copays in the initial phase, to a 25% coinsurance. So great, we fixed it, right? So no problem. But there are a couple things that I think are worth noting. The way that the coverage gap got closed was asking manufacturers, drug manufacturers, to pick up 70% of the drug costs in the coverage gap for brand name drugs. For generics, plans just cover those costs. This will come in handy in just a minute when I tell you about some of the problems that this accidentally created. But just kind of keep in mind that when we said we're going to fix the benefit, they basically fixed it by pushing those costs onto the drug manufacturers themselves. The other thing that I think was really frustrating for someone like me who studies really expensive drugs that the benefit didn't work at all for, is that closing the donut hole doesn't really do anything to help people who have really expensive drugs. And one of the reasons is that if you fill a cancer drug on Medicare Part D, you blast all the way through the whole benefit in your first fill. So you go through your deductible, the initial phase, your coverage gap, and you go into the catastrophic spending on your first fill. So closing the coverage gap, or closing that donut hole, it doesn't really save you as much money if you're taking high-priced drugs, because a lot of your spending is concentrated in that 5% catastrophic coinsurance phase. So what we did is we took a look at whether or not closing the donut hole helped people with cancer drugs. Turns out no. Drug price increases over that same period of time completely erase savings for out-of-pocket spending for beneficiaries, because those price increases ended up just erasing all those benefits of closing the donut hole for people with cancer. So we still have a substantial problem. And note, these are out-of-pocket expenses that would be paid by someone filling 12 months of cancer therapy. You see this axis, $12,000, $14,000, $16,000 a year out of pocket for one drug. Another thing that I think is, has been historically a suggestion is that, we just need to wait for generic entry, right? Like generics work, that's the patent system working, you get a patent, you get to price your drug however you want, eventually we'll get generics and things will be low cost. But the fact is that doesn't necessarily always work out, and for specialty drugs, high-priced generic drugs for cancer, we haven't seen the same price reductions as we have with the small molecule market overall. So if you thought about a cholesterol medication, for example, that a lot of people use, we tend to see their prices drop really, really fast after generic entry. But instead, when we think about more rare disease markets, we don't have as many generic drug companies entering those markets, and so we don't get the same price competition. So this is an example of the amounts that were being paid under Medicare Part D over the first several years from a generic entry. So these are the actual amounts going at the point of sale for Part D plans. You can see that the generic prices eventually do drop with that black line, but not really as quickly, definitely not as quickly as we should expect, and they're still quite high. So you remember the 70% coverage gap discount that pharma's paying for brand name drugs? In essence, what happens to patients in this situation is that if you look at what they have to pay out of pocket, that 70% that the drug manufacturer is paying gets counted as out-of-pocket spending for beneficiaries. So it makes them go through the coverage gap faster, and then it basically means they actually have to pay less of their own money to fill their drugs. So if you compare the out-of-pocket prices that patients would have had with the brand name drug Gleevec, the red bar, and the black bar, the generic imatinib, and that's not a messed up axis. This is what happened to patients. So patients who waited a really long time to get access to a low-cost generic ended up seeing their out-of-pocket prices go up, and they stayed high for years. So clearly, like, red flag, need to fix this, right? Like, we don't want to ever send the signal that generics are more expensive than brands. And then the other thing that's just like, let's just keep piling on, like that I told you, therapy dog, right? Like, I need to bring one with me for this. There's also a lack of patients' assistance programs. Once a generic enters the market, drug companies stop donating money to patients' assistance programs that actually help people to pay their copays. So one of the ways, even though Medicare will not allow individuals to use coupons from drug manufacturers or direct assistance, you can use grants from foundations. And a lot of foundations are set up for helping people with cancer afford their copays for their drugs, but that money goes away when a generic enters. So you end up in a situation where your plan stopped covering the brand, you only have access to the generic, it costs you more, and you've lost your copay support. Also, this is, when we're talking about Gleevec, you need to stay almost perfectly adherent to this drug or you can develop resistance. So we're talking like 95% adherence is kind of needed to avoid having a bad clinical outcome. So there are some serious ramifications to having even small gaps in your treatment use. Well, I think I've pretty much hammered this home. It's pretty bleak out there for people on Medicare Part D who need cancer drugs. So let's look specifically at this. I feel like this is just something that people kind of miss is how expensive. These are the most commonly filled cancer drugs on Medicare Part D over the last couple of years. And this is an estimate of the first fill cost based on actual Part D benefit designs in the US. You cannot shop your way into a plan that covers cancer drugs generously because no one wants to cover cancer drugs and get all those patients who have cancer, right? So everybody has just really poor coverage for these drugs. You end up in a situation where your first fill is over $3,000 a month. The first fill. Like, just imagine, you go to the pharmacy and they're like, that'll be $3,000. Like, my eyes would bug out of my head. I have $3,000 I could pay for that, thankfully, but I would just be like, are you kidding me? Like, I would really have lots of other things I'd rather buy. Then you also have this situation happening here. We're talking like $10,000, $12,000, $14,000 out of pocket to use these medications for the whole year. And many orally administered cancer drugs are used by people until their disease progresses. So it's like basically when you stop them, it's because your cancer is growing while you're still using them and you need to move to something else. So you're kind of on them until that happens, or for the rest of your life in some cases. This doesn't include doctor's office visits, scans, your medical benefits, your premiums. This is just your cost for one drug. And you could probably get the sense, I don't like putting words on slides, but I can never remember how horribly low the median income is for somebody age 65 in this country. So I always feel like it's worth putting this up here. So I've spent some time writing this piece about this disconnect between the coverage for your medical benefit and your pharmacy benefit on Medicare. And the fact that if you were an older woman who was diagnosed with breast cancer, the subtype of breast cancer that you had would dictate whether or not financially you could manage it. So basically, one of the lesser common types of breast cancer, HER2-positive breast cancer, is treated almost exclusively with infused therapies. Most Medicare beneficiaries have supplemental coverage that reduces their out-of-pocket costs or makes it nothing. So, or either you're on Medicare Advantage and you may have an out-of-pocket maximum on that plan. So that's more manageable. But if you have the more common type of cancer, there are newer drugs that are being recommended that could cost you $10,000, $12,000, or $14,000 annually just for that single drug. So the subtype of cancer would dictate whether you, a Medicare beneficiary, are going to be dealing with a financial catastrophe or not. I also think it's noteworthy that, we often think about people who qualify for low-income subsidies, and that does provide more generous coverage on Medicare Part D, but the threshold for coverage is so incredibly low. So what we're talking about is basically that if you were looking at an older woman, she'd have to spend nearly half of her gross income to fill one of these cancer drugs, and she would still have income that made it she was too wealthy to afford subsidies. It's just like mind-blowing that that's the system we're in. I promise I'll land on good news, but not yet. So we did some work, and this is the project I think I will probably love the most for my entire career. This was a long time coming and a lot of data work, but we worked with 11 different academic medical centers around the country to get information on prescription drugs that were being ordered for patients at these different sites. And we focused on people who were getting new orders for prescriptions for orally administered cancer drugs and who had Medicare fee-for-service coverage. And then we linked the records from the patient-level medical data to their fee-for-service Medicare claims to see, like, from the people who have an ordered prescription, what % pick them up. And the red bars represent the typical Medicare beneficiary who does not qualify for low-income subsidies. So these are people who have a little bit more income, but obviously not incredibly high income, but some of them could be there. And the any subsidy group are people who qualify for low-income subsidies that basically mean that when they go to fill this same medication, it costs them about $10 instead of $3,000. And you can see here, these are examples by drug, but we found overall 30% of Medicare beneficiaries who had new prescriptions ordered for them by their oncologist for orally administered cancer drugs never filled them. That is shocking. These are people going to some of the best cancer centers in the country. And they are getting the specialized care, getting these recommendations, and they're not going through and filling the drug. And this didn't vary based on the value of the drug. So you might say, okay, well, some of these drugs might not be that helpful. That's true, but we actually did not see that discrimination across like whether or not the drug was very beneficial or not. This is incredibly alarming, I think, when you think about the human toll, like the idea that you don't fill your drug. Maybe that is a rational choice for many people, but you've just had a conversation with a doctor, you're dealing with cancer, and you are making a decision, a financial decision, that probably makes you feel like you're choosing between pursuing treatment and spending this money or dying. And that is an incredibly awful thing to have to deal with as a patient and as a family member. So, I think one of the things, John really set this up nicely for the Affordable Care Act, and sort of the dichotomy we have with some policies versus others. Drug pricing has been a long-standing bipartisan kind of issue where if you ask pretty much anybody, they would like drug prices to be lower. They think that Congress should do something about drug prices. They think there should be limits on what people pay. So it's not like this is a politically contentious issue from the perspective of actual regular people. And in fact, the Trump administration was very vocal about trying to lower drug prices and push that type of agenda as well. But it has been hard to get anything done. So why has it been so hard? I mean, because there's a lot of people making a lot of money because drug prices are high is part of the reason why it's hard to change. There are also legitimate concerns and questions around when you lower prices, if you're too aggressive, what does that do to investment in the industry, which I think are important questions and worth considering. But I think that there has just been this long-standing fight politically, despite how popular it is with consumers, to get anything done. And this felt like a roller coaster ride to me as someone who'd been watching this closely and wanting them to fix at least the Medicare Part D benefit for a really long time. It felt like it was close to happening, I'd say multiple times, probably 2016 felt really close to something happening, then 2019, you're like, okay, something's gonna happen, nope, and yeah. And if you talk with people who've been studying this for a long time, they're like, yeah, we were having the same argument 30 years ago. And you're like, oh, great. This is not good. But something did happen. So we got the Inflation Reduction Act last year. This was, as someone who trained as a pharmaceutical scientist and not as in health policy and health economics, I felt very grateful to have read an excellent book about about the Affordable Care Act and its passage through the reconciliation process, because otherwise I think I would have had no idea what was happening. I was like, how is this happening? But we ended up in a situation where we were able to get Medicare Part D redesign, drug price negotiation, and many other things as part of a budget reconciliation bill that required only 51 votes, which ended up getting a 50-50 with Kamala Harris being the tie-breaking vote and getting the Inflation Reduction Act passed. So how does the Inflation Reduction Act actually impact drug prices? There are three key things that it does that we'll focus on. The first is that it introduces drug price negotiation for the first time in the Medicare program. As I mentioned at the very beginning, negotiation already happens quite a bit when there are head-to-head treatment options. So we would be kind of ignoring the elephant in the room if we didn't say, actually, pharmacy benefits managers and plans negotiate a lot already, but there are places where negotiations aren't successful because of different rules about mandatory coverage, for example. But this allows negotiation at a broader level, not just within the health plans or the plan sponsors, but across all Medicare beneficiaries. The negotiation limits the focus to older drugs. So they have to be 9 years old or 13 years old, depending on their small molecule or biologic. They can't have generic competition, or as CMS has now clarified, bona fide generic marketing. That's going to be really in the weeds. We could get to that in Q&A. And there are a couple of other exemptions for who qualifies or not. The easy part is, or the very prescriptive part is that these drugs get selected based on gross sales in the Medicare Part D program in this first year. And what that basically means is you just sort the drugs by total gross spending. You're ignoring all rebates and discounts, just gross spending. There's maybe some debate about whether that was the best idea. And then you pick from the top of that list down. So we already have the first 10 drugs that have been identified for negotiation in the first year, which their prices would go into effect in 2026. And so it looks like we're making some steady progress, although I'll have a next slide that's here are some challenges. Another key provision is limiting price increases in for all drugs. So This is a helpful provision and something that Medicaid has done for a long time and has saved the Medicaid program a lot of money by limiting price increases to the rate of inflation. So as I showed you, those cancer drug prices going up far and above beyond inflation, that won't be allowed anymore, and any price increases above inflation will have to be paid back to Medicare. So that's going to be a source of savings for the program. And then there's Medicare Part D redesign, which is near and dear to my heart and will actually solve pretty much all the problems I showed you from the beneficiary perspective, which we should all be thrilled about. Basically, if you know someone on Medicare Part D, even starting next year, their coverage is going to be so much better than it ever has been, and if they need expensive drugs, they will be able to afford them. So next year, what happens is that the 5% coinsurance in the catastrophic phase gets dropped. So you'll basically spend at most about $3,200 out of pocket next year. And then in 2025, there will be a $2,000 annual cap on Part D spending. So you would not spend more than that in the year. The other thing is all those multiple phases of the benefit go away. So you end up with a very simple benefit that basically says, okay, your plan either offers your drug at a copay every time or coinsurance every time until you hit that cap. But imagine how much better that will be for most people because they could actually predict what they would owe for their drug for the most part. And even for people with like a preferred brand name drug, let's say you take a blood thinner but you don't have any other medications. Theoretically, you'll have a flat copay for every fill on your plan, or you should be able to get into a plan that does that, versus today that even with the closed donut hole, your price goes from a copay to a coinsurance as you switch from the initial phase to the gap. And that has caused a lot of price disruptions for people because you go from paying maybe $40 a month to paying $140 a month. And that's really disruptive to people. So lots of good things coming. But there are some threats to its success that I think are worth mentioning. One of the first is that you may have heard that the companies that have drugs selected for negotiation have all sued the government to try to stop the negotiation process. And the crux of their arguments are really around kind of constitutional challenges, like their constitutional rights are being violated here. There are concerns that this isn't a real negotiation, that they will be forced to say it's a fair price when in fact they don't believe it's a fair price. There are more nuances to this, but I am not a lawyer, so I'm gonna let a lawyer handle those. But by and large, the industry is responding as we would expect them to respond. They really do not want to engage in price negotiations, and this is exactly as we expect. So we'll have to see what happens with the lawsuits. What happens if the lawsuits are successful and drug price negotiation gets dropped? In talking with individuals who know much more about the law than I do, the other parts should still be able to stand, which would mean that Medicare beneficiaries would hopefully not be at risk of losing these important changes to their benefit design that we all hope they get. Nevertheless, we have to pay for that expansion of benefits. So when you think about, if there are 30% of people not filling their cancer drugs because they can't afford to, and now they can finally afford to, we may actually see a substantial increase in Medicare Part D spending as a result of improved benefit design. Even those same changes of like going from a copay to a coinsurance today, we know disrupts adherence. So we should expect people to fill more drugs, fill them more consistently. And, we would like to be able to pay for that. And negotiation is part of how, at least the intent was to be part of the way we paid for this. There are also possibilities of the industry evading negotiation, which this is kind of, if you are really into the rulemaking process, it's like CMS is putting out additional pieces of guidance, and you could already see really interesting like financial analysts would say, okay, here's how they get around it. So it's very fascinating to me as somebody who's like interested in this space to see all the ways that people are guessing the industry will just bypass being selected for negotiation. And then also, where are the loopholes in the law that would allow for gaming? One that stands out to me and that I've written about is the issue around generic entry. What does that mean? So we have seen examples where companies have had generics approved and enter the market, but when the branded drug company really controls that drug's market share. So that's not really true generic entry. That's sort of fake generic entry. But CMS has to be really explicit about what counts as generic marketing and what gets you out of contention for negotiation. And then the last thing I want to mention are new drug prices and the challenges with new drug prices. So negotiations target older drugs, and we have much more generous coverage on the benefit. What happens with new drug prices? And, I've heard a range of responses to this. So I think the general economics argument would be that if companies could have gotten more money, they already would have. Okay, that's probably fair for most of the market. And also where there's competition, companies aren't just naming their price. They're setting their list price, but they're not getting to name their net price, really. They have to deal with other drugs in their class, other drugs to negotiate against. I'm worried about those rare disease drugs, the drugs without competition, and the drugs that have mandatory formulary inclusion, including all cancer drugs. So I think it's going to be something to watch is the newer drugs that are coming onto the market and how high are their prices, and do we see an even bigger jump in launch prices of new drugs, because now you can't raise your price at will, at least in Medicare, and you also may be subject to negotiation after a set amount of time. So these are the areas that I would say are of concern to me as someone who's interested in having the Medicare program hopefully exist when I age into it, which is a while still. So I guess this is fine, right? We got some pros and some cons. I think as all things health policy and thinking about new legislation, we do have some really promising things that are coming for both affordability and access to medications, but there are a lot of looming challenges, not just the ones I mentioned, but John mentioned another set of challenges, things like the drugs for rare disease or for gene and cell therapies. He mentioned a $2 million drug. There's a drug that's now over $3 million per person, and we have more coming. So these are going to be really one challenge. Another broader set of challenges are what happens when we have highly effective drugs for large populations. Obesity medications that are very highly effective at helping people lose weight and minimize their chronic disease burden, but that cost $1,000 a month for 40% of the population potentially. So, Alzheimer's drugs, we have all kinds of problems. So there's no shortage of work here, I guess maybe is what I'm saying. But I will say that there is at least some good news. For patients, the affordability challenges are going to be modified a bit. For the system, we'll have to wait and see how it plays out. All right, so with that, I'm going to take a breath and take some questions.
So thank you, that was really good. And we love high-priced drugs in oncology, so thank you. What I'm curious about with the Inflation Reduction Act is that it really focuses on Medicare. So, and the pharma companies, of course, are working outside of any individual payer or outside of even the United States. They're global organizations with lots of space for the balloon to squeeze. So what are your thoughts about if we negotiate just between Medicare and one of these drugs, what they're going to do to the prices for commercial payers or or even list prices, but for commercial payers who are getting their, who are not being subjected to this, or don't have the ability to negotiate in the same way.
Yeah. So I think that it's, there have been people debating this, like, what is the spillover effect going to be? And I feel like a lot of people have landed on that if they could have gotten higher prices in those other markets, they would have already been doing that. I think we may still have those challenges where we have drugs that don't have competition. Maybe there is a spillover in that case. But I think it's going to depend primarily on how much competition there is within the drug class. I'll say the other thing that I think is kind of instructive looking at the drugs that make the top spenders list this first round. So we had 10 drugs that were identified in Medicare Part D as the drug subject to negotiation. Like 9 out of 10 of those have a lot of brand name competition. They probably have very large rebates. So the way that CMS has, or the law specifies that the negotiation will go, is that there are some minimums, like at least 25% discount, kind of, that's going to be the minimum discount on kind of younger drugs. And then, or they could use the current net price. They could decide that's a fair price. Or they'll do some cost effectiveness analysis and try to define like what's a fair price based on a lot of information from the industry and some back and forth. You know, I think that a lot of people who are watching this closely think those negotiated prices for competitive drugs are possibly fair prices. So there's a good chance that for many of the drugs, probably 9 out of 10 of them on this first list, that the fair price might look very close to the current net price that the manufacturers get. That's my guess, at least for some of them. The one that I think is going to have a substantial price reduction is the cancer drug that was included on the list, because we know that those don't get very much in rebates or discounts today. But spillover, it's possible, but I think that in general, the economic argument would be that those companies, like if they had leverage to get a higher price, they would be getting it now.
Dr. Russell, she opened up sort of the same theme of question I have. So in Medicaid, I guess the rule is commercial negotiations, whatever the lowest price is, minus 23 or something %. That's our price. So my question is, when they were authoring this policy, why didn't they just go that easy route as opposed to a whole negotiation arm with all of these manufacturers? Just say, I'll let the commercial payers do this, Aetna's, United, et cetera. I'll just take their lowest and then, you know, minus some. And it'd be so much easier than all of this stuff. Is it just for optics? Like, oh, we're doing something, or just curious?
Yeah, that's a really good question. So some of this was piggybacked a little bit off of H.R. 3, a bill that was passed by the House in 2019 that had a very aggressive set of drug price negotiations included in it, that included both Medicare and the commercial market, included many more drugs, not just older drugs, and that basically said we'll pay, I think it was 20% more than what other countries pay. So you're going to index our price off of other countries with similar economies to ours. And that was wildly unpopular with the pharmaceutical industry, as you might imagine. And in fact, the Trump administration tried in a similar tact around the same time that they were going to set international reference pricing. So there were a couple of efforts to actually just say, you know, everyone else is doing these negotiations. Why are we going to just duplicate all this effort? Let's just take their price, pay a little more, and call it a day. I think that that was very much probably fell by the wayside because of politics, but I don't actually have as much insight into that component of the negotiations and like why it changed so much. There was certainly a big shift from some of the original framework of the Build Back Better Act, which is what the Inflation Reduction Act was built on, that kind of came about as senators were negotiating, you know, their preferred policies and what it would take to get them to vote yes for that law. That's why we have these weird, like, drugs that are 9 years old or 13 years old if they're biologic, and you're like, what? But yeah, simpler would be better, but, you know, we don't do that in healthcare.
What are your thoughts about Mark Cuban's pharmacy that he started, Cost Plus Drugs? My second question is that what are some spaces for private players in the market, I guess, to have like an entrepreneurship system or innovate to reduce their prices because, obviously have less power to affect the government policy. So.
Yeah, so I'm a big fan of what the Mark Cuban Cost Plus Drugs company is doing in the generic drug space in particular. So for those who don't know, he has, and there are other groups doing similar things, but they basically are offering people an option to pay cash for their drugs and buy directly from their company. And they have, so Gleevec, good example. I think the price today for Gleevec, that if it were on a Medicare Part D plan, is probably close to $1,000 at the point of sale for a 30-day supply. It's $40 or something like that on his website. You paid cash, bought it directly, maybe even a little bit less. So there are definitely some areas where just directly paying cash and not using your benefits the right way to go. I think the problem is there are two scalability issues. One is that insurance companies haven't been all that excited to partner with companies offering the lowest price drug, which is really not great for society. But there have been attempts, for example, I've heard this for Humira biosimilars, for insulin, where there's so much benefit to insurance companies and PBMs to get a drug with a high list price and a high rebate that they want to pick that drug even if it's worse for the consumer. And they won't necessarily make the deal with the lowest priced product, which again, as a consumer is very frustrating to me, but that's a part of the reality. The other downside about those cash pay programs is it basically bypasses your health insurance, which is fine for generic drugs where most people could pay cash. But once you start with brand name drugs, even if you got a super highly discounted price, it's still too expensive for most people to pay. And then why are we paying for health insurance? So if you asked Mark Cuban, he'd be like, we should just get rid of health insurance. And I'm like, well, but that pays for a lot of things. So maybe let's, agree to disagree on that point. But I think it's a very good innovation. I just think that it's hard to scale because of some barriers in the system where some of those actors are making a lot of money off of the current system.
So you got me down the path of talking about PBMs, and I mean, there's lots of stuff going on in Washington now trying to rein in some of this that you just talked about in terms of here's our list price, but here's the rebate and stuff. So your thoughts on that part of it, especially on the commercial market?
Yeah, so there has been a lot of focus on pharmacy benefits managers, and in Congress right now, I kind of joke it's the only bipartisan thing that's happening in our Congress right now is like everybody's mad at PBMs. And most of that legislation, though, is targeting transparency into the system. So knowing who they're working with, how they're paid, what they're paid, and how they're paying, their pharmacies, et cetera. So there is a lot of emphasis on legislation that's like, we need more information, which I am fully behind because I think it goes back to one of the prior questions about like, well, would transparency be bad? And it's like, that has always been the argument here is like, if you have price transparency, then prices will go up for these drugs. This industry is highly consolidated. Like, I think the three largest PBMs have over 85% of the market or something like that. So I think that they're probably getting similar prices to one another, so I'm less worried about price transparency. As far as like the broader issue, there is a real concern about this rebate game. So when a PBM or health plan decides to cover, let's say they want to cover the high list price version of Humira because they get a huge rebate and it ends up being the lowest net cost drug for the plan. And then they send that through to the patient at a co-insurance or a deductible. That is highly offensive to me because it's like, I'm fine with the companies picking the lowest net price drug. That's what they should do. But they should protect the patient from getting hit hard when they do that. And that's one of my frustrations working in the specialty drug space, is there's so much use of co-insurance on all of those drugs that you end up in a situation where like the plan might benefit from lower cost drugs, but the patient isn't. I don't love solutions of just passing through rebates at the point of sale, which was part of what the Trump administration attempted to do. And actually that's one of the reasons we have the Inflation Reduction Act, is canceling that paid for the Inflation Reduction Act provisions in some part. But that has been shown that it would increase spending pretty dramatically. It depends on how you operationalize it. And right now, I don't think we have enough transparency to know how to write regulations that would do the jobs we want and not have a, huge increase in spending on the backside.
Okay, so I got a little bit lost on your response, which means that some other people would be lost as well. Do you think there's potentially a simple policy solution in terms of what to do with rebates?
Yeah, so my simple solution would be charge the patient co-pays, disconnect their price from the list price, and let the plans just duke it out, and the PBMs, and they figure out the rebates. So that's just my view, in the fact that I would like to see the patient's cost disconnected from the list price, which doesn't really have any kind of foothold in reality. So if we could move patients over to co-pays, I think we know that would be better for them, from like their price would stay the same from one fill to the next, and it would avoid many of the downsides that are happening right now because of rebates. So if I said your cost is a $50 copay every time, it doesn't matter if your plan's getting a bigger and bigger rebate and the list price is going up, it doesn't matter, because your price is fixed and not related to that list price increase and that rebate increase. If instead I said your price is 25% co-insurance, then all of these games that PBMs and manufacturers are playing around the list price are going to harm you directly. So my view has always been design formularies that allow people to access their drugs at co-pays that disconnect them from the list price.
Okay, and that requiring that rebates be paid directly to the customer could potentially raise costs, is what you're saying as well.
So if you pass through the rebate to the customer at the point of sale, so that's been one of the arguments, is like if the company gets roughly a 50% rebate and you're paying a co-insurance, reduce their list price by that amount and charge their co-insurance based on that lower price. The reason I don't love that as a policy is because a lot of people take drugs that don't get large rebates. And so before we have Part D redesign as it is set up now, when that was the solution that was being proposed, that basically says if you're taking a drug that has a lot of competition, you get to benefit from this policy. But if you have a drug that has no competition, this is the only drug for you, you have a rare disease, you don't actually benefit, and in fact, you're probably harmed because your insurance premiums may go up to try to make up those losses. So I actually think that co-pays get us away from both problems in a way that's more fair for everybody. But I think it is that concern that not everybody takes drugs that get rebates, and we want to make sure that people aren't harmed by having that be the way we try to solve this policy problem.
Okay, makes sense. So while we're talking about transparency, I've always wondered, why can't we require transparency on the R&D and development costs of drug companies? Because really all this is we just don't know what the profit margin is because they're not reporting their costs. So we have Medicare cost reports for every other provider.
Yeah. So I guess this comes down to how much do you think R&D costs have anything to do with the price of a product? And I think that they're disconnected. So I think that the industry can use that to point to why they want their prices to be high. But if you have a great drug and it costs you barely anything to make, you're going to price that drug as high as you can. And if you have a not so great drug and it costs you a ton to make, you're going to price it as high as you can, but maybe you can't price it as much because there might be less interest in using it. So in some ways, while I think R&D costs are important for us to kind of generally understand, to recognize that it is a high cost investment to develop a drug, I'm not sure that your eventual price should have anything to do with your input prices. Like if you make a drug and it happens to not really help people, we shouldn't pay a ton of money for that, even if it costs you a lot to develop it. But I do think they're important measures. I'm just not sure how much they should have anything to do with the ultimate price that we set.
Yeah, okay. And so these foundations that provide assistance to purchase expensive drugs, would they be allowed to buy plane tickets overseas?
It's possible. I actually don't know the scope of it, but and in fact, I think that they operate in slightly different ways. But one example might be that some of these foundations may do things like they provide you with a grant that allows you to pay for a set of costs. So, for example, maybe you apply for assistance and you get a $5,000 grant that comes in the form of like a debit card. And you can use it for different things. You can use it for parking at your cancer center. You can use it to buy your food while you're on the site. You can use it for your copay support. I think it's pretty variable what form these come into, but I know that transportation is part of it. Whether they send you overseas to fill your cancer drug is a question. I would guess no, but that would be kind of fascinating if that did happen.
Yes, so I think the R&D cost is a really interesting angle to look at. I guess my question is, what about the failure rate of all the programs that didn't succeed, which are 9 out of 10 or whatever? Mm-hmm. And I point to one company called Gilead, which is like just a hero company because they do some awesome science. They've had numerous failures in the last couple months with some of their anti-CD47 trials. So at what point is it fair or sort of acceptable to fold in some of those failures into the few successes?
Well, I think when people do estimates of how much it costs to develop drugs, they absolutely do include the cost of failure in those calculations. So when you see, I mean, it's a broad range when people say it costs X dollars to develop a drug to Y dollars. Like that range is incredibly large, and you're like, that wasn't that helpful, right? Like 100 million to billions, right? Like, but they do factor in the cost of failures in that development. And in fact, this is one of the things I find to be really interesting about, right after the Inflation Reduction Act passed, there were some very public statements by companies about killing off different products earlier in the pipeline. Like, oh, the Inflation Reduction Act is already like causing us to lose innovation. We're gonna just stop these drug developments. Well, one of the things I think is important to recognize is the incredible failure rate. And so are we actually pulling the plug on things earlier? And that's a good thing because they were already kind of questionable about whether they would have made it through the next phase of trials, which require huge investments. So I actually think there are, some positives to thinking about being a little bit more intentional about like what is a promising molecule and thinking about how could we reward real benefits, like where we see signals that are large benefits for patients, so we get those drugs that we really want, and we stop funding so much development on drugs that don't provide anything but, maybe just tiny incremental benefits. Thank you so much.
Well, I hope you enjoyed all the four speakers as much as I did today. Thank you so much for coming. I wanted to thank, we can't do this without the staff. Thanks so much for Brenda Laymans and Mara Short for helping to organize this conference. We actually have a great audiovisual team out behind, and many thanks to them, and thanks for our event staff in terms of making everything run so smoothly. So we hold this conference every other year. If you liked the material, please tell your friends, because this will all be available. It'll be processed very quickly, so within, by early next week, you can access all this either through the Baker Institute website or it all goes through YouTube. so you can, even speed up the talks and run them faster if you have less time. If you like the material, we do this every other year, so if you have thoughts on what you'd like to see a couple years from now, our email is healthecon@rice.edu. Love to hear from you, and thanks very much. Enjoy the weekend. Bye.